Awesome.
Okay, I guess we're all here. Okay, welcome everyone. My name is James Orbinski. I'm the director of the Dahdaleh for Global Health Research here at York University, and it's really a pleasure to welcome everyone to this now annual workshop on critical social science perspectives in global health. It's essentially, as the title implies, the idea of the workshop is to explore ideas and critical perspectives from a social science lens as they apply to global health. And to do that in a manner that is really focused on our three themes, which are planetary health, global health and humanitarianism, global health foresighting. And with that focus, it's a lens that is not focused inwards, it's actually focused outwards. So it's a wide spectrum lens. What we're trying to do, and we have been able to do quite successfully over the last few years, is just create a space where we can explore new ideas at York, and where we can actually support the emergence of those new ideas and the more detailed exploration of those ideas. We have a seed grant program where we offer a $5,000 seed grant to support the exploration of a particular idea. And Anna is going to tell us a little later on about that and how to apply and what the actual process is. It's very simple, a one-page application. You just simply have to say what you want to do. And then the committee, we have a review committee which will review all applications, and then we'll choose basically 5. This year, as in previous years, the format of the workshop is very simple. We're going to have a very, I hope, interesting exploration of some ideas around critical social science perspectives in global health, just as a kind of a framing from Haris Ali, who's here now, and I'll tell you more about him in a moment. And then we're going to have some updates, very brief updates, from the recipients of seed grants from last year. And can you go to the next slide just so people can see the head? Yeah, perfect. Then we're going to have, so this is 9:45. Then we're going to have some research updates from recipients of last year's seed grants. And then Hannah will, as I just mentioned, give us an overview of the application process for seed grants. And then we'll have some brief presentations, 5-minute presentations, on some proposed ideas that people are thinking about and looking to explore. And then we'll just have a sort of a summary, a 5-minute summary, and then we have a little bit of a very light lunch for people at around 12 o'clock. So that's the format for the day, or for the morning. It's a very simple format, very informal. And I encourage people to ask questions either in person or if you're online to raise your hand, and we will respond. I'll try to keep a close eye on that. Hannah will as well, so that if there are people who've raised their hand, we won't miss it. So that is essentially it. And with that, I just want to do two things. I want to just give a formal land acknowledgement, which I realized I neglected to do. So I just want to acknowledge that we are situated on the traditional territorial area known as Takaranto, and we acknowledge its current treaty holders, which are the Mississaugas of the Credit First Nation. And we also acknowledge this as the traditional territory of many indigenous nations, which include the Anishinaabe Nation, the Haudenosaunee Confederacy, Huron-Wendat, and of course the Métis. And this territory, this territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and care for the Great Lakes region. And I would also encourage people who are not physically present here at York just to take a brief moment and to recognize and to give thanks for the land, the physical land that you are actually on. And with that, I also want to just mention that this is not just a sort of an accidental kind of gathering. A lot of people have worked to make this happen. And on the steering committee for the Critical Social Sciences Perspectives in Global Health workshop are Amrita Dahdaleh, who's here today. Thanks, Amrita. Eric Mikolovsky, Rhonda Ferguson, who I believe is online and who is going to be taking notes throughout the workshop. Professor Roger Kyle, Associate Dean Ravi DaCosta, and of course Harris Ali, who is here now. And with that, I'm going to turn it over to you, Harris, and I'm going to ask you to give a very brief kind of description of yourself. But I will say that Harris and I and others here at the Institute have worked very well together on many, many different projects. And Harris is a sociologist with a focus on global health, and particularly on the impacts of outbreak of disease, and most especially Ebola, for example, in West Africa, or COVID here in Canada. The impacts of outbreak and pandemic disease and the interaction with social and human institutional infrastructure is incredibly insightful. And I will say that over the years, my 5 years here at York, Harris is one of a group of people that I just have taken so much from, intellectually and also just socially, and I've learned so much from. So with that, Harris, I'm going to ask you now to just give us just some initial reflections on global health and on social science perspectives on global health. Okay.
Yes, thank you, James, and thanks for the introduction as well. Is it possible to actually move those, like, that, margin? Yeah, that's excellent. Yeah, just because I have a lot of images here. You know, James asked me to give some reflections on my experience on global health. And, you know, I'm relatively new to the area of global health. I mean, the most sort of experience I had with global health was as a student, where I did a sociology of development course, you know, and even that, it was a sociology of development. My supervisor was a person who was interested in regional development, because he was from Newfoundland, and he was seeing how that region of Canada was underdeveloped compared to the rest of Canada. So even my sociology of development was a bit weird. But, you know, I have studied different infectious disease outbreaks throughout Canada and North America, like SARS and tuberculosis amongst the homeless and Walkerton and things like that, but not really in the global south until this situation with Ebola, okay? And what was happening was that the DRC was experiencing a very bad epidemic of Ebola. And West Africa, that's Guinea, Sierra Leone, and Liberia had already gone through outbreaks of Ebola. Okay, this was in 2014, 2016, around there. And 11,000 people, unfortunately, lost their lives in West Africa due to Ebola. And after a sort of initial unsuccessful campaign to keep the disease under control, efforts were made to sort of turn the tide. And these efforts were based on a certain strategy that I'm going to talk about today, which is known as the community-based initiative. Okay, so community involvement in epidemiological response, right? So the idea was this, that we would take knowledge about the successful community-based response in West Africa, particularly in Sierra Leone and Liberia, take the lessons that could be learned from that and apply it to the situation in the Democratic Republic of Congo. Okay, so this was the idea, to take knowledge of a successful response and take it to another part of the continent. Okay. And so our own research, I should say, was based on collaboration with teams in Monrovia and in Freetown. Okay, and in particular, and it's a person I'm going to be talking a lot about, in Monrovia, the person who led the disease response during Ebola in the capital was Dr. Misoprostol, and he's probably one of the most brilliant men I've met, and he was basically my partner in Monrovia, and we worked with what was called the Sierra Leone Urban Research Center in Freetown, which is headed by Joseph McCarthy. So the idea was to do focus groups and interviews and find out what was, contributing to the success of the outbreak response, and to jot those down and hold the sessions in the DRC. Okay, so that's sort of what we tried to do. Okay. So again, the idea was to take knowledge from the West Africa outbreak and to pass it on to the DRC, which we did through a series of workshops in the DRC and Kinshasa. Now, a lot of this work was around the table, which is interesting to me, at least for this part of the research. So this was our connection to the DRC. He is the Minister of Public Health. Okay, so there's also a Ministry of Health and a Minister of Health, but this is the Minister of Public Health, and he reports to the Minister of Health. So he's the Minister of Public Health for the DRC, and this is Misoprostol. Okay. So we did interviews also in Kinshasa. This, you know who this is? Jean-Jacques Mayombe. He is the discoverer of the Ebola virus, right? He was in Masoka. He was in awe, because he got to see his hero, And anyways, we interviewed him as well. This was in the counselor. He was a Liberian in the Liberian embassy in the DRC, right? And so, anyways, we held a series of workshops to talk about the community-based response. Now, I want to talk about some reflections, and then I thought back. For me, the whole experience was different. My family is, I was born in Canada, but my family is from India, right? But I've never visited India, right? And so the developing world was still at a distance. And I remember, I was showing pictures to my mom from this research, and my mom is kind of like looking at me and says, "You don't have any idea. This is what I grew up in." Right? And it's like, "You idiot." I was like this kind of thing, right? But for me, it was an eye-opening thing, and it came right from the airport. The planes weren't going into the Ebola-related areas, right? Or after Ebola, they still didn't continue. Anyways, you would take the plane to Brussels, and then you would switch to, another plane that would go into the various African countries. And then you do a switch over to another smaller plane to get to other towns. And I never experienced this, but I saw different groups of people in these smaller airports, like people who were women dressed in very modest clothing, like long dresses, because they were missionaries, Christian missionaries and humanitarian people, and also like rich businessmen, right? It was a different experience for me, right? It was even that was eye-opening. And then you go in that Brussels airport, and you have the area, which is for the Western travelers, full of croissants and coffee and nice things, statues of Smurfs. And then you go to this area which goes to the West Africa, and there's nothing there. It's like it's a de facto apartheid. I couldn't believe it. Anyways, all this was new to me because I'm talking about reflections. So anyways, what happened is Dr. Misoprostol works for NPHIL. It's one of the directors there, National Public Health Institute of Liberia, which is formed right after the Ebola response. Okay, and in NPHIL they have various meetings that had the fortune to attend, like the WHO meetings and things like that. Now what happened was, on the first day that I arrived in Monrovia, jet-lagged and everything, and Misoka got the NPHIL driver to come and pick me up to take me to Enfield, right? And I got to know this driver very well because he took me around to all the sites where I would do interviews, right? Anyways, so the driver picks me up. He says, listen, I'm going to Enfield, but do you mind if I stop off and pick up these bottles of water for the office? I said, I don't care, like, you know. So he said, okay. We stopped in the parking lot of this warehouse, and he says, okay, I'll go in and get them, you know. You just wait here, right? So then 5 minutes later, he comes back. He says, she wants to speak to you. Like, what are you talking about? Who wants to speak to me, right? He goes, the dispatcher, the warehouse dispatcher, right? So I go into this warehouse, right, full of these bottles of water, and then this woman goes, you're from Enfield, right? He said, well, I'm not from Enfield. I work with somebody from Enfield. She goes, yeah, so you're from Enfield. Sit down. I want to talk with you. Pull up a chair, right? So I pull up a chair, and this, you know, wooden creaky chair that barely holds my weight, and I'm sitting, and this woman is just across me. So, you know, we have been eating bush meat for centuries, she goes. She goes, so why is Ebola all of a sudden here? It can't be because of bush meat, as you guys at Enfield say, right? How is that possible? It counters my experience. She didn't use those words, but that's what she was saying, right? And I'm thinking, you know, yeah, she kind of has a point, right? I'm not going to get into a discussion about environmental changes and deforestation and invading viral reservoirs and all this sort of stuff. She's using local knowledge, and she's got a point in my mind, right? Because what was going around was a lot of these rumors that Ebola is a fabrication. It's made up by the government officials, NGOs, in order to attract money into the country, right? That it's a ruse. It's fake. We don't actually have to worry about it. So these rumors, and I want to talk about these rumors later on too, okay? But this is a woman who was talking about this, and it was very real to her. But to me, it opened up the whole idea of the importance of local, contextually based knowledge and the importance to pay attention to that in a disease response, right? That's what I got from those initial meetings. This is Masoka, my friend there, and we'll talk a lot about this too, in a particular informal settlement, one of the largest in Africa, called West Point in Monrovia. Okay, so in reflection, as I was going through, I think, okay, well, what really had left an impression on me with this research? One of the things was, you know, as I was alluding to, the importance of a community-based response. The other thing that came up was the sort of perennial or perpetual issue of capacity building, okay? Third issue, the reflection, can social scientists involved in global health remain scientifically neutral about the political conditions in the global south? Okay. And I think for me, this is the most important one. The commonality of human experience during a disease response. You know, I've been, you know, doing stuff on COVID, and I would send things to the conversation, and I'd say, listen, I want to do a piece on Ebola and COVID. And the immediate response is, no, well, Ebola is a completely separate disease. It has different transmission dynamics. It's in the global south. COVID is different. They're not right, you know, because there is something common in terms of how people react to disease. And I don't care whether it's in the global south or in the global north, right? This is why things like rumors and conspiracy and mistrust, vaccine hesitancy, it's not just in the global south. It's in the global north, right? And so I think this is an important point, right? So first reflection, the importance of community-based response. Community engagement needs to be authentic and pragmatic while connecting to real local conditions, relationships, and power dynamics. Okay. So what is this community-based response? Well, basically, it was a response where members of the community are recruited, deputized, whatever you want to, in disaster management, which is an area that I teach and do research in, it's called deputized, but they don't use that term in public health. people are recruited to be involved. Lay people are recruited, to use the term citizen science. They're not actually doing science per se in the sense of research, but science in the service of public health. People are recruited to be involved in the public health response, and they're trained to do so. So the basics of a public health response to disease, contact tracing, case identification, monitoring, all these sorts of things, right? And so lay people could be trained to do the investigations to see who has the disease and to trace the contacts rather. Very interesting stuff that Misoka developed. Like these days, everyone is on the cell phones, right? And, cell phone records, they don't have this strict privacy kind of thing that they do in Canada. Cell phone records Misoka used to trace contacts, because people would be phoning their relatives and stuff because they say, oh, the official is coming, don't come to town or whatever, right? They were hiding cases of Ebola. The reason is because government officials would take the sick and they would never be seen again, right? Or they didn't bury the people with proper, dignified, and respectful way of doing it, especially for the Muslim and Christian and the other religious people there, right? So they didn't want the bodies taken away. So they weren't revealing who had the disease, Anyways, response training and case identification and contact tracing, raising community awareness and education, implementing hygiene measures, community surveillance of disease incidence and spread. This I found very interesting. Like in the West Africa, I didn't know this before, but the village chief, right? The village chief is the person who is responsible for the village, and this includes so-called villages even in downtown or in the cities. It's the community leader. Anytime you visit a village, the guests have to come and meet the village chief first. And the village chief does kind of an interrogation. This is why are you here? Who are you staying with? Does that person vouch for you? All this sort of stuff, right? In a way, such an individual is already doing community surveillance and monitoring, something that is so important for disease response, right? I mean, I didn't know this. When I would go for the interviews, I'd go with the guys there, and they would take, I would go meandering around in informal settlement. I go, where are we going? And they're just taking me around. Like, they're taking me to see the chief. No idea. And you don't even know, because it's an informal meeting. It's just, hey, how you doing? Yeah, okay, what's your research about? But I didn't realize this is a protocol, And the people had proper, manners and grace not to make me feel like an idiot, right? So anyways, community surveillance of incidents spread, implementing isolation, quarantine, and triage measures. Listen, if people are quarantined, then somehow they need to get food and water, all right? So informal structures were set up by local people to provide that food and water, okay? And this informal thing is very important. Right, and we'll talk about this later. Because in areas where there's a fragile state or failed state, the government is not able to engage in the provision required for the collective provision, And so people have to take it for themselves and provide for themselves. And that's what the informal economy is about. The informal economy is already there. And I said to Misoka, what you've done with your community-based initiative is you've tapped into this informal system already existing, and you've kind of molded it for a disease response. Now, that's essentially, in my mind, what he did, right? Anyways, community-based intervention may have helped prompt a change in people's risk perceptions and level of trust they invested in other groups as EVD outbreaks unfolded in Liberia. Because if you have more and more local people involved, particularly local leaders, their word is more likely to be trusted than an outsider, right? That's just a natural sort of thing, right? So, we may not know the local politics of a certain area, but in most cases, the local village chief is trusted, right? And if that person makes a certain direction, says to stay home, to report anyone who's evading the quarantine, if there's any secret burials taking place, right, it will be reported to someone who's more trusted, right? These local leaders played a huge role. Like, one of the things with Ebola was the survivors. People didn't want to go to the Ebola treatment center. They were scared. And there's reasons that I understand why that's the case from the people's perspective. But, people would go to the Ebola treatment center, and they would get better, and they would return to the village. But they were stigmatized, right? But what a local village leader would do is go and embrace the survivor who comes back to the village to show that there's nothing, to worry about, sort of thing, right? This gesture by the local village chief had a lot of impact. So we did, our interviews. This is with faith-based groups, local groups. This is the West Point Informal Settlement, West Point Muslim Community Council, right? This is the imam of a local mosque in another area. A very nice person, right? This is in Monrovia vicinity. This is in Freetown. These are nurses in a community health center. So what Musoka there would do is the first thing that he would do is call all the local leaders in the vicinity to a town hall meeting, and he wouldn't say anything because people were very upset at the government response to Ebola. So he said, listen, I'm not saying anything. I understand that you're angry at the response. What can we do? What do you want to do, right? And this is how we get the input, right, through these town hall meetings. I'll talk about this later because this idea of town hall meetings, I think worked well for Musoka in Monrovia because he's from there. He grew up in West Point. He knows the people and he knows the local politics. But, Musoka is a West African, myself as a Canadian, to go to DRC, we don't know the local politics, right? If you have a town hall meeting of all the leaders, I don't know what's involved in that. Anyways, I'll talk about this later. So people were trained to do things like contact tracing. This is a local person, probably shouldn't give confidential information like this, so I trust you'll keep this in here. So people would go to house, see how many people are infected, keep track of who died, things like this. This is in contacts, right? Done by a local person. Okay, so then all this information and strategies that we gained about the community-based response, we conveyed this through a series of workshops in Kinshasa to the Minister of Public Health and the Minister of Health. Okay, so different workshops were being held to deal with that. Now, this is another problem for me. My French is abysmal. And, the DRC is a French language speaking country in part, and everything was conducted in French, right? So anyways, the government did decide to sort of use a modified version of the community-based response that was done in Liberia and also in Sierra Leone to operationalize their own, what they call community animation cells, okay, in certain areas of the DRC, okay. And we proposed, Musoka and I, to do a sort of pilot study to see the effectiveness of this, okay. The Ebola outbreak in the DRC was complicated for certain reasons, mass movement of people, civil war conditions, and community resistance, particularly based on distrust. And so, the most affected areas were Butembo, Katwa, and Beni in the North Kivu province. So this is the sort of data collection that we're interested in getting. This is a community-based response. You visit a number of households, you ask about the number of people who are sick. I think one visited the Ebola treatment center. How many people are deceased in that? So these are the sort of this is part of the community-based response, right? That the local people will be trained to do, right? And we would keep track because it's all about surveillance and monitoring, right? So, after we did our workshops in Kinshasa, then we went to Goma, which is on the eastern part of the country, and but the situation was getting worse and worse. but we're trying to establish connections, there. This is with, these are women traders that would cross the border into the bordering country every day to do trade. Okay, but as I said, the situation was getting worse in the DRCs, and the Ebola treatment centers were being burned down, and attacks were being made, and things like that. I was worried. Masoka was worried, and so I said, Masoka, you really got to find out what's going on over there, right? So Masoka, emailed his contact. So, Masoka, coming from poverty conditions, it's a very successful story. He went to Harvard to do his Master's of Public Health, did his PhD in another American university. But through that, he made connections through Harvard. And this is another thing in the reflection. The people in these Ivy League schools, especially like in the United States, they have this circle of connections in this so-called cultural capital, which I don't have. Right? I don't have the liberty to go out on these field trips for weeks at a time. I have to teach and do service, right? It's a different, anyway. So Masoka called on his network of people. So this is an email exchange with, it was actually, the late Paul Farmer, one of his students, right? And he says, look, we're in Goma now, and he says to this guy, he says, this guy's responding, he says, also, I don't think this study could be conducted from Goma, since this is not a site of Ebola transmission. It is where coordination has moved because of all the violence in Beni, in Butembo. Conducting this particular project would be dangerous. Over 10 people were killed outside the city yesterday alone. And today we are trapped at the WHO office because of security concerns. In addition, all of us had to take a three-day security course in French in Goma to be able to come up here. Okay, so Masoka, thanks, brother. So you won't advise me to come there in the future? Maybe in Ecuador province where they have previous small outbreak, but all the areas of the current outbreak are dangerous. Then he says, this guy, Harvard professor, he goes, perhaps if you could come visit me in Beni, we could organize a guide, translator, and an armored vehicle. My boss and the Minister of Health got attacked today driving into Beni, right? And then, Masoka was asking other people at this National Institute of Health, right? He's asking, is it okay to travel to these places, right? So I agree, it is not safe. So we're checking into this sort of thing, right? But then certain developments happen over the course of the next few days. So this was our connection with the DRC. He was the Minister of Health, right? Now, he was involved in who we interviewed as well. And he was, caught in some scandal and was let go. So our connection to that country was severed, okay? And then the vaccine was developed as well. So this led to a whole certain other sorts of issues, right? And in fact, the vaccine trials for the Ebola vaccine were developed in Liberia, right? And Masoka was part of that, right? And then soon thereafter, then the COVID struck too, on top of everything, right? So then at that point, we couldn't go there anyways. Okay. Now, one of the things that came up was this idea of capacity building, okay? Post-colonial history has meant that groups have come and gone throughout history, no sustained solution leading to a perpetual problem. We talked about like the weak state and the dependency kind of structural relationship that occurs, which I'm sure you guys in international development know about already, okay? And these are some of the reasons that perhaps informal capacity is developed, because as I alluded to before, if things can't be done by the government, you have to do it by yourself, right? So the question is, what can we do, right? Because one of the things that struck me is when I went there and started doing the interviews and working with Masoka's group. He had a group of young students there and activists, and I went to talk with them, and the reaction was, okay, well, what can you do for us? Personally, me, right? And it's like, what can you do for capacity building? And then I'm kind of like struck by this, what do I know, right? I'm an academic, right? And I thought, well, yeah, that is what I know. Like, I know how to do research at least, right? So maybe I can build your capacity to do research. I don't know what else to do. I'm not a doctor like you, James. I can't go and treat these people or whatever, right? Now, this idea of capacity building, it really, and how it's like inconsistent, really struck me there. So on one of my trips there, Masoka said, look, I'm going to New Crewtown. New Crewtown is another informal settlement north of Monrovia, north of West Point. And he said, I'm going to drop off these textbooks. You want to come? I said, yeah, sure, I'll come. So I went to Masoka's house, and then I helped take all these books and put them in the back of his vehicle, or, and there are tons of books. And then I said, I'm dropping it off to the school. So we go there, and there's this huge crowd of people waiting for Masoka. This is totally unplanned. This is a surprise thing. What was happening is the community was establishing a sort of scholarship in Masoka's name, right? And they were going to and a foundation to get money in order to buy this. This is their school, right? And it was interesting experience. I'm sitting behind Masoka, an outsider. This is like the school house. This is the whole school. This is one classroom. Like, you can see the condition that it was in, and they're all singing songs of praise, right? Because he led the successful response in that area. And, I'm sitting behind him and just, taking this in. It's a surreal experience for my pampered hands. And then Masoka says, yeah, just say something. So what do I say? I said, oh, you're lucky to have Masoka, right? Anyways, so the idea was that you would have the money, then they could buy this new school. Yeah? And then we went on a tour of this school. But I went into the school, and what struck me, and the first thing I saw was this. And I go, what the hell is this? This Canadian flag. And I'm not part of this NGO world or humanitarian. Like, it's not my world, right? I go, what is this, right? Right to play, then I, got back to the hotel, Googled it, and all that sort of stuff. But here's the thing. This is what happens all the time. The NGOs come in, they work for a while, and then they leave. And so this is why you have this school abandoned, right? So as I said, look, what can I do? For their capacity building as a researcher, and here's Roger Tal, from environmental studies, who I, kind of forced to come with me on one of the trips. And, I did a workshop previously on thematic analysis, the qualitative analysis. And now this is a workshop on, manuscript development, right? And this is another thing that I learned that's very important, these certificates. So anyways, we, did these workshops, and we did actually come up with an article, and these are the members of the team, Steve and Tina Myers and Morris. Okay, third reflection. Can social scientists involved in global health remain scientifically neutral about the political conditions in the global south? Because all the time you have these sort of signs. This is actually an NPhil about, scientific research. I found this interesting, here, this one. Why do health research in Liberia? This thing about health research is not as clear-cut as it would seem. One of the reasons, and I discussed this in another paper and other talks about vaccine hesitancy, which you hear about in the north, but it's also in Africa, because there were cases of abuse in the protocols. People were recruited for experiments. Pfizer was involved in this without proper ethical consent. And so people were not given things that would help them. I think there was a case of meningitis or something like that. And they know of these situations where they're basically being taken advantage of for vaccine trials, right? And so, yeah, why do health research in Liberia? Well, it's not simple. But what I found interesting is this. What is health research? And this is, it can also address social and economic factors that are associated with disease. sanitary conditions, water shortages, deforestation, etc. I found that interesting because it leads to a more encompassing approach to health, which is what, I'm sure most of us agree with here. But again, a lot of the research is done from, from supported by global north countries, right? And they have their own biases in there. So this is Masoka's office, actually, and then I see the sign, Centers for Disease Control, the U.S. Now, part of our team was actually Roger's brother-in-law, and he's a vaccinologist, right? And he's involved in this team that are developing. This is a mobile Ebola treatment unit. So what it is here's this treatment unit that folds in half and it can be attached to a truck and taken to the site, right? So anyway, debates about what social scientists should do, what role they should occupy, and whether cooperation with Ebola response actors implied complicity in various post-colonial global health and humanitarian projects remains unresolved. And these are complex issues and they require further discussions, okay? And anthropologists of all the social scientists, they've done a lot of work actually in this Ebola response, and quite amazing work actually, if I may say so. Social scientific work, and one of the lessons from their sort of work was that build relationships, attend to cultural norms, give respect and deference to traditional leaders, and informal social and political systems. In that one sort of statement, that's the whole basis of community-based response. Okay? Work with rather than against local populations. If people are disregarding health communication messages, the problem may lie well with the message and the messenger, not with the audience. So I agree with the anthropologist Sharon Abramovich, who's done a lot about Ebola in West Africa. For the radical alliance of social scientists with local populations, global health justice, long-term commitment to health systems and human rights, as well as opposition to violence, coercion, and passive or active abuse by powerful institutions. So getting back to what I think I put down as the original question, can social scientists involved in global health remain scientifically neutral? Based on my experience and reflection, I would say no, right? And I've written about this with my friend, his former PhD student, Jarrett, about this by applying the work of Fanon. Okay, the post-colonialist conditions, suspicion, and social resistance during the West African Ebola epidemic, the importance of Frantz Fanon for global health. Another thing that came up with this research, and it was a thorny and difficult kind of thing, is which voices were elevated or silenced during social scientist engagement. Okay, so this is from the editor of British Medical Journal, Global Health. Foreign experts who write about local issues without acknowledging how and why their real audience is actually not local experts, but other foreign experts. So I'm writing for other privileged people, right, about Ebola. Foreign experts who set out to write for an audience of local experts without acknowledging the limitations of what they can possibly know about local reality. So Masoka asked me one time, he was teaching a graduate course at University of Liberia in public health. So Harris, come and speak to this class. We can do it remotely now during the pandemic. I said, fine. And then I went in with this, like, what can I possibly tell you guys, about your reality? It's like ludicrous, right? So what I could tell you, though, is your approach, pay due diligence and respect to the local people and their circumstances, and don't look down upon that, That's the most I can do. I don't know the local realities like you guys do, okay? It was funny, like my only, I had a skewed version of local realities because, I was telling you I was going around to the various sites with this driver, and this driver would listen to this one talk show, right, with this on radio, right, and it was a talk show where people would call in, right, and they would talk about all the local issues that were going in, and then this guy was spelling out all this stuff about the politics of life here. And I said, who is this guy, to the driver? He goes, well, he's a guy, he's doing his studies in the United States, and he's broadcasting from there. I go, oh, that's bizarre. Anyway, local experts who write for a foreign audience without acknowledging how the imagined audience influences what they study and they write, right? So, you may be in the global south, you want to impress the global north audience, that may influence your writing, right? These sorts of issues are important issues, right? There will always be gaps between what local experts see and what foreign experts can possibly see. But more and open conversations on the place of the foreign gaze of local knowledge and of organic rather than surgical changes in global health are and can help us identify other strategies to fundamentally undo colonial practices and attitudes. And I thought, yeah, this is pretty enlightening for editor of VMG Global Health. Now, this is actually the most important thing. I'm running out of time.
Yeah, it's okay. Keep going.
Okay. The commonality of human experience during a disease response. You see, the stuff that I saw in Ebola, I also saw with COVID, right? Fear, othering, stigmatization, racism, conspiracy theories, trust issues, especially of the government, vaccine hesitancy, politics, right? All these are still occurring because we're dealing with the human condition. I don't care what disease outbreak you're dealing with human beings, right? And as human beings, we deal with all these social, psychological, cultural, economic, political aspects, right? And so, when I talked about how people thought, oh, it was a government conspiracy, Ebola is a fabrication to get money in, right? Well, they're saying that in the global north too, with COVID, right? Conspiracy theories. Issues of trust, also, right? Oh, you can't trust the local government. Oh, you can't trust the government here, right? Going backwards.
Yeah. There you go.
Yeah. Political mistrust is a big thing. I can't get into it now because of government response. Basically, West Point is on a peninsula. Government officials came overnight and just put up barricades so that people couldn't leave, right? And they said, well, we're doing this to protect you guys. We're building an Ebola treatment center within West Point to serve only West Point people. And this is it. This is an abandoned school, which they turned into Ebola treatment unit. But the people were suspicious. They were saying people from outside West Point were being transported to this Ebola treatment unit, right? But as I said, all this sort of mistrust is also going on in the north, right? All the time. Okay? So take-home message. I'd like to highlight what I personally take to be one of the more important points from the reflections. The need to emphasize the commonality of human experience, fostering an empathy based on such a perspective, I think will serve to address the issues raised in the other reflections. And I would even go further as to say that the emphasis on the commonality of human experience should form the basis of contemporary perspectives on global health. This is my own personal opinion. All right, so thank you.
Well, I'd just like to point out that as Harris described his experience, what he described to me when I listened, what he described was fresh eyes, bringing a fresh perspective to a set of practices that for those within the systems that practice various approaches to global health don't necessarily see or don't see easily. And for many people within those practices, they often, and I'm guilty of this just as much as anyone else, they often either dismiss or minimize certain insights or perspectives in the interests of "quote unquote" getting things done. What getting things done in a timely, emergency framed manner. And I think what Harris, just has brilliantly in terms of his slides, but also just in terms of his demeanor, his way of being, his way of actually interacting with people is very genuine, very authentic, very real. There's no artifice, there's no kind of self-inflation, if you know what I mean, self-importance. What he's demonstrated is, to me, very clearly, is the centrality of fresh eyes, of seeing things with a clear mind and with a clear way of being, and to kind of maintain that even as you gain experience and so on, but at the same time to learn from that experience, but to constantly remain fresh, remain open, I think is the key thing that I have gleaned from what you've said. I have many questions, Harris, but you pointed out that a couple of key questions. Can social science remain scientifically neutral about the political conditions in the Global South? Gave a very clear answer from your perspective. And then you also came down very clearly on the commonality of human experience. And I just want to offer this to you as a suggestion and also as a point for your reflection. Social science and social science, science in its broadest sense, is a way of asking a question with a view to eliminating the biases of subjectivity. Right. Now, at the same time, you come back to this core idea of the commonality of human experience, and then you also interrogate very clearly, can you be scientifically neutral? And what I would suggest is that inherent in the scientific process is a recognition that there is a reality that we don't yet fully understand, right? And so we have a way of formulating questions and methods so that we can more fully understand reality. But that is an inherently moral choice. There is an inherent recognition that there's a difference between what I know now and what I seek to know, and that I seek to know with a view, not simply to know, but with a view to improve.
Yeah, that's the difference.
So there is an inherent morality there. Yeah. It's a moral choice, right? So, and I think that's good. That's right. And I think the way that you kind of where you arrived, in terms of being very clear about the commonality of human experience and trying to recognize what that is relative to what the good, quote unquote, can and should be, I think is actually a brilliant formulation. So anyway, that's just a reflection, and there are many thoughts that I have, and I'm sure others. But can you reflect on that? And then I'm just going to invite people here who may have thoughts or questions to share. Go ahead.
Yeah, no, it's a difficult one to respond to in a sense. I think you put it very well, and I agree with what you said, and I think based on your own sort of humanitarian background, you've had to delve into those questions, right? And had years of experience to do so. For me, I haven't really had that, right? But I do like that idea of the science in the service of what, right? And it is I think that's true. Other than that, I don't really know. I haven't thought along those lines so much, right? But you've comforted me with your answer somehow. So, yeah.
Any thoughts or comments? Just raise your hand. Go ahead. And just introduce yourself very quickly. Just your name and.
Yeah. My name is Alexis Porter, and I'm currently in my first year of the PhD at the anthropology department. So
before you say anything, probably 20 years of really profound, practical humanitarian experience that with UNHCR, with many different NGOs, around the world in some of the most complex and difficult situations that we can imagine. So go ahead.
So I was a humanitarian advisor to the British government during COVID, and okay, that's nervous making. And there was a very much, it was recognized that because of Ebola, people in that part of Africa felt very comfortable and competent to move forward with the COVID response because people had kind of practiced already. So
dress rehearsal.
The WHO, all the NGOs, everybody was like, okay, we've done this, we're ready, we've been talking about this, we will take that to this environment. And then I was thinking about the connection with local people, but also around gender. So what we did was we partnered with the London School for Tropical Hygiene and Medicine, right? Yeah. It was young Sudanese researchers who were actually based in London who then came in to support. So on the one hand, that was difficult because they were from an elite in Sudan, obviously, to be able to get out and be in London. But on the other hand, they were young. They were women, and they were well connected, and they understood the culture on the ground. Keep the multiple parts of it, right? And they were really able to engage, and that helped inform our and other policy around how we could research and how we could respond. And so I sort of wanted to ask about, you know, if you look at some of your photos, right? So you've got all the men. There were 2 women in the photos. You didn't tell us who the women were. And then you talked about the importance of traditional chiefs and senior leadership. But I think that photo was all men. I think there was one woman maybe in the background in green. You know, the village chief isn't always the person. And as you know, the sociologist, local hierarchies of power often oppress and restrict the most vulnerable. And, you know, when we look at West Africa, for example, with the sex scandals and things in the early 2000s, often it was the people in power who took advantage and created the abuse.
No, absolutely.
So I was just sort of wondering about, I guess, all of that, you know, gender, power, hierarchy.
It all plays in, and it's always absence for these presents. I was on a panel once about sociological theory, right? And then there was a young woman there, and then all the rest of the people were men. And then, you know, you do a write-up, and it was published in Canadian Journal of Sociological Review or whatever. And then I was reading this, and she goes, "Oh yeah, and I'm the only young woman on a panel of all seniors." And I thought, I'm senior. Like, so the age thing comes out, you know, so it's always these variables are left out. But you're absolutely right about the gender, right? And the gender even played a role in the methodology because the focus groups had to be segregated because sometimes the women were not forthcoming in front of men, right, in response to certain questions, right? So, you know, certain of those focus group interviews were done and that. And even when in one of the interviews that I did, like with one of the local people, you know, the leader and his wife were both there, but I was only addressing myself to the male. And the sort of student who was with me said, "Well, ask her questions." And I says, "Right," but I was nervous and everything too. The other thing though is gender is so important in this. Because, you know, they say that Ebola is a so-called disease of love. Because the thing is that this particular disease was most transmissible, when the person was most suffering, okay, and even after the death, right? This is why funeral activities were so crucial in spreading the disease, critical in spreading the disease. And oftentimes in the, you know, if you want to call it patriarchal society, that's fine, the caregiving functions are performed by women. And the women are the ones most vulnerable, therefore, for getting the disease, you know, because of the caregiving facilities. That's for sure, right? But yeah, no, that definitely played a role for sure, right? And you know, people have studied that as well. And in fact, you would know better than I these days, you know, even for, you know, grants dealing with international development and all, they want to make sure that the gender dimension is addressed, you know, for the very reasons that you brought up.
Well, Canada has a feminist international assistance policy. It can't just sort of be addressed. It has to be.
Oh, yeah, that's what I meant. Yeah.
Yeah. Okay, so Rhonda, go ahead.
Thank you. Thanks for your presentation. Just to hone in on some of the criticalness of the project and the presentation, you touched on this idea of the foreign gaze, and I'm wondering if you could elaborate on that a little bit, if that was something, if that was a concept that informed your work, and to what extent.
Yeah, I mean, I came upon that later on as I was going through the reflections, like after I had already started sort of collecting the data with the groups of people involved. And yeah, that wasn't something that was, that I had dealt with earlier on, to be honest, right? But now in retrospect, if I continue to do work in this area, that is something that I will take into account.
Blessing.
All right.
Just introduce yourself very briefly. Blessing is a postdoc here at the Institute and at the Faculty of Science, focusing on use of artificial intelligence and machine learning to better understand COVID and also vaccination strategy, and also approaches to clinical public health in local and pandemic disease context. Go ahead.
All right. Thank you very much for your presentation. And it was quite interesting to see that you pointed out what is happening in the Global South, which is where I'm very much interested in. And I see that you also mentioned about vaccine hesitancy, which is also what I'm actually working on right now. So I was trying to find out if there is any strategy that your team or you and your team use to find a way to ameliorate the issue of vaccine hesitancy in the local communities. And also how to also get the information from them to know why they are being hesitant about the vaccine. Because I do research on that concerning the identification of the vaccine hesitancy hotspot, especially in Africa. And it will be interesting to find out from a first-hand information, I would say direct source, because you went there to them, you interacted with them.
Yeah.
Did you have any idea of why they are not taking the vaccine? What are their fears? And is there any strategy that could actually be deployed to actually ameliorate that?
Yeah, the vaccine was introduced in the later stages where basically my research had finished. But, I would say some of the things that there were these various sort of conspiracies that were going around that, this is an attempt to eradicate the black race or to make people infertile. These sorts of conspiracies were going around. But, I don't think they should be dismissed out of hand, because I think, as you were getting to, you said, why were these people believing like that? There has to be a rationale for that, right? One of the things is this hotel that I stayed with, there's this like South African guy who's working bottling companies there, and he said, look, a lot of the stuff you talk about is because these people are uneducated. I said, no, it's not because they're uneducated. They have a reason for thinking like that, right, based on their own local experiences. And I think the aim of the researcher should be to get at why that's the case, right? That vaccine hesitancy that you're talking about based on local experiences, why is it that case? And social media these days is everywhere, and it spreads a lot of stuff, and I think that plays a big role, that social media stuff. And there was something else about that, not the vaccine hesitancy, but I'll come to me later, I'm sure.
Well, I'll just add that in Sierra Leone, one of the still very present lived experiences, literally in people's lives, not in their ancestors or in previous generations, but in their lives. People have lived civil war, and they have lived through 18 years of civil war in Sierra Leone. And I mean, I can tell you terrible stories about the reality of that war, where people were victimized, openly and directly victimized by government soldiers openly and directly victimized, and when I say victimized, that's a euphemism for having their hands cut off, having their feet cut off, having their ears cut off, all raped on a mass scale, all in an effort to subjugate and control different groups of people in different parts of the territory as the war was evolving. So people have lived this. And if you even go into villages, even today, 20 years later, 30, 25 years later, you'll see people with no hands. You'll see people with no feet, with no ears, with machete wounds across their face. This is the lived, embodied, actual experience of people. So when government says, do something, there is always an explanation, and it's never lack of education, which is, to me, whenever I hear that, I always think, well, that tells me about the person who's saying it.
Yeah.
It's telling me that they are deeply ignorant and willfully ignorant of the so-called, what you're calling, local reality, right? So that's what it tells me. But so in the same way that government is not trusted by people, generally speaking, in that context, the same is exactly true for UN agencies, because UN agencies during that war were variably aligned and working with, and I say variably because it changed as the war changed, right? With government and or with NGOs and or with corporations. Multinational corporations doing exactly the same thing, right? Paying private armies to subjugate, right? And then at the same time, pharmaceutical companies, Harris alluded to it very quickly. Very specific pharmaceutical companies were actually using people as guinea pigs, literally as guinea pigs for vaccines and for drug trials, without any respect for their basic dignity and without any recognition of their future right to access the fruits of that medical science, of that knowledge that was being conducted, and the trials that were being conducted on vaccines and on certain drugs. And so I tell you all of this to say, and NGOs, exactly the same story, all driven by their own little power dynamics and their own little needs to be, seen as good and seen as worthy of donor money, and all looking for their perfect PR moment, right? Which some of us in the room are very familiar with. So the power dynamics that were and are still very much at play influence how people see and how they look at a situation. And we can talk about vaccine hesitancy, even about drug hesitancy, and about many, many different things. But the bottom line is that trying to see with fresh eyes how people see, how another person sees a situation. This, to me, is the root of social science research, right? Yeah. That is the essence of what a good critical perspective in social science research should bring to global health, right? And so I just want to really thank you, Harris, for, we couldn't have had a better presentation, not only in terms of the actual content, but also in terms of the way of being, the way of doing things, being yourself, being authentic, and not being afraid to ask tough questions or to see things in ways that actually challenge your own certainty, your own kind of confidence, if you will, in previously held views. So thank you for that, Harris. Yeah, really, really helpful. I really, really appreciate it. And with that, we're just going to go right into our short presentations. And I'm going to ask Jeffrey Squire to prepare. Hi, Jeffrey.
Hello.
I'm just going to give welcome, Jeffrey. I'm just going to give a very, very brief introduction. I'm going to leave it to you. And I'm going to ask the presenters to please try to stay within 5 minutes. And I know that's a real challenge. but please do your best. We'll really appreciate it. So Jeffrey is talking about COVID-19 and healthcare waste management in urban contexts in Africa. And the project that he's going to talk about looks very specifically at COVID-19 management of waste products associated with COVID-19 in Ghana and Rwanda. And not much is known about appropriate waste management for healthcare products. And he's going to talk a little bit about the historical kind of issues around waste management of healthcare products in Ghana and Rwanda, and look at how these have changed or not in relation to COVID. And also we'll probably focus on dissemination of critical knowledge. So with that, Jeffrey, a very brief introduction. I turn it over to you. Welcome.
Thank you, everybody. Thank you for having me. Let me share my screen here. Just for the record, I have a class at 10:30 today, which I've just sent them a note that I may be running late. So if I had to leave right after the presentation, please forgive me. I'm not trying to jump ship here. I just have a class at 10:30 to go to. And so it's gonna go, and I'll try my best to be very brief. So my current research focuses on COVID-19 and healthcare waste management in Ghana. And healthcare waste, to my knowledge, since COVID, some of us here are wearing our masks, the pharmaceutical intervention strategies, testing, vaccinations, and caring for patients all contributes to the generation of some amount of healthcare waste. Now, how do we manage this waste, especially in the global south context? And how is the situation unfolding, especially given that in the past 2 decades, there has been outbreaks of infectious diseases all over the world, affecting 30 to 180 countries to the global pandemic. So my case study looked at Ghana, which is in South Africa, between Ivory Coast or Côte d'Ivoire, and Togo, and the Burkina Faso on the top. So the country has a population of 32.83 million people, which is almost evenly split between male and females, and land size is around 238,000. And in addition, there are over 4,000 healthcare facilities in the country. And since the outbreak of COVID, there has been over 20 million vaccine doses administered. And so you can imagine the amount of waste that is generated as a result of taking care and inoculating people against the disease. So my objectives were to assess the overall state of medical waste management since the pandemic, and also to examine measures put in place to ensure effectiveness in the process, and look at current policies, and also explore feasible strategies for amelioration within the constraints that currently exist. And so I use semi-structured interviews as part of my key data collection tools. So also survey questionnaires, and then I also visited healthcare facilities and waste dumps to see how this is all unfolding at the moment. And I also undertook a critical review of the literature, and just to position myself well for this research. And so what did I find? I find that and to Harris's previous presentation, this is not, the outbreak of infectious diseases is not new in the African context. Ebola came. Ghana, of course, did not have huge cases of Ebola, but it's been around, and also the global pandemic. But one of the things that I found was that the policies in place for managing healthcare waste during the pandemic are very ineffective. They are incomprehensive and they are vague. And so an example is the medical waste guidelines, which exist as a signature for managing healthcare waste. It lists the types of waste and the approaches to managing it. Now, I found that this guideline hasn't been updated since 2002. it has been around, nothing has been, and there is currently no guideline for healthcare waste management in Accra. And the existing guideline, which was published in 2002, lists infectious waste, pharmaceutical waste, radioactive, incinerated ash, and the proposed management options. But then when you look at it, steam disinfection, incineration, cement and casing, landfill, there is not a single landfill in the entire country. They don't have healthcare facilities that I visited do not have disinfection equipment or microwave equipment for microwave irradiation. They don't have incinerators for incinerating medical waste. And so I found that the problem is due to lack of financial, technical, and human resources, which results in the lack of infrastructure. So for example, like I said, the entire country doesn't have a single sanitary landfill. There are no properly functioning incinerators, and treatment facilities are non-existent. They don't have none. And so what happens is that it results in unsafe storage practices, which allows for public access. And when you look at best practices for managing healthcare waste, it has to be stored securely to ensure that the public do not have access, or animals or scavengers do not have access to it. And then I also found that there was infrequent collection of healthcare waste, which leads to accumulation of waste. There's non-treatment, and then there's also crude burning of waste as a way of reducing volume and toxicity. And because there is no healthcare facility, there is no landfill in the entire country, healthcare facilities dispose of their waste indiscriminately, causing environmental pollution and public health risks. So this is what I'm talking about. I take a lot of pictures as part of my research. And so on the left here, you have the recommended storage procedure for knives, scalpels, and other sharp objects for managing healthcare waste. When the COVID outbreak occurred, the WHO, the World Health Organization, provided these cardboard boxes for managing sharps in Ghana. Now, the problem is this is not puncture proof, right? You put a scalpel in here, you put a knife in here, you put a used needle in here, it can puncture the box and cause injury or infection to humans. And so when you look at the recommended storage approaches to on the left here, you have best practices, locked and secured. It has to be stored in puncture-proof containers with wheels at the bottom to ensure that it doesn't fall over or people do not carry it on their head. On the right is a photograph I took in the main COVID treatment center in the capital city of Accra. They don't have a place for putting waste, so the waste is put outside, deposited outside of the COVID ward, where then it is carried by informal waste carriers to various destinations, which are also designated land dumps or sometimes undesignated. And so realizing how dangerous this is, the healthcare professionals and the doctors and nurses that I found, they've devised their own way to store their needles. So here you have a gallon here, where that is now being used as a needle storage receptacle. Behind the gallon, in this picture, I wasn't allowed to go too close, that's why the pictures are like this. But when you look at behind the gallon here, there's also a water bottle here. They recognize that this is very unsafe for needle storage. So they've been putting needles and other sharp objects into these gallons and bottles over here. Again, same healthcare facility. This is what is happening with COVID waste. And the problem is, this is a reservoir of pathogenic microorganisms, right? Contained in this waste are infectious agents, they're bacteria, fungi, and viruses that can cause diseases to humans. So again, I found that in another ward, because of the unsafe nature of the cardboard boxes, they use these containers to store their needles and sharp objects in their hospitals. This is another polyclinic, a lower tier healthcare center that I went to, and this is what they have there. The healthcare waste hasn't been collected for weeks, leading to accumulation. And as you can see, these are cardboard boxes. And so this is a combination of both regular waste and infectious and hazardous waste put together. Another healthcare facility that I visited where the waste hasn't been collected for weeks, leading to accumulation. And so when it comes to transportation, on the right here, I have a picture of best practices. This is vehicles used for the transportation of healthcare waste must be safe and secured and disinfected regularly. On the left, I followed this tricycle from a healthcare facility because I was able to establish contact, and they told me when they will come to collect the waste. So I followed them, and then this is how healthcare waste is being transported from one healthcare facility to the landfill or open dump site. And this is the dump site that I visited. As you can tell, this is not engineered, it is not safe. And you can see that it's an open dump. It's an open space where healthcare waste and all types of waste are dumped here. You can see people, the presence of scavengers and waste pickers on the waste, and the picture is blurry because I don't want to show the identity of these people, but this is a site where a lot of scavenging and waste picking activities take place. So you can imagine the risks that is posed to healthcare, the public health as a result of that. This picture shows recyclables that has been recovered from the waste stream, from the open dump that I visited, and a few of them. So people actually collect these, pack them, and wait for it to be sold to people who are involved in waste recycling. So all of these were picked from the waste site and put, and by the way, this includes beddings from healthcare facilities, from patients that have been treated with COVID. Okay, and so here you have a lady who is sitting down here waiting for the truck to come by and collect the waste from that has been picked from the dump site. So what are the risks? What are the implications? Why is this important? Why am I talking about? It is because of risk of infection. Everybody you see on that waste has families. On that dump, they has families. They will probably go home. They will go to their work site. They have a high risk of infection. And then when you look at the boxes that it was given by the World Health Organization, it poses risk of needle stick injuries. And the problem with sharp objects is that whether they are infected or not, they can still cause injury. And then there are also other diseases that may occur as a result of exposure. And so this, just quickly, just to wrap up, I know my time is up. This is what we are talking about here. These pathogens, right, either bacteria, virus, fungi, or parasites, are embedded in the waste. And then people or animals, as we see, or the soil, the food, if this leaches into the waste stream, it becomes a reservoir for it. And then once there's a portal of exit, when humans being reservoirs or animals, through coughing, sneezing, bodily secretions, and fecal matter, there's a risk there. And the mode of transmission can either be direct or indirect, or also through vectors, as we just saw. The portal of entry through the mouth, nose, eyes, or cuts in the skin. And the most susceptible agents here or hosts for this are the elderly, the infants, and immunocompromised. Anyone can get diseases from the mismanagement of healthcare waste. And so when it comes to the environment, I only have 5 minutes for this presentation, so I cannot go further. But when you look at crude burning, for example, it causes air pollution, which is linked to global warming and climate change. And then there's also the effects on aquatic species, as well as the contamination of surface ground and drinking water sources. And there's been research upon research that is pointing to feminization of male fishes in rivers due to exposure to healthcare waste. So why do we have to care about this? What is the implications? And this is where I conclude. Professor Harris Lee talked about Ebola in West Africa, right? Diseases have come in the past 2 decades, Zika, Ebola, Middle Eastern Respiratory Syndrome, everything. And we've seen that with these diseases, they are transboundary. They move, SARS, all of them, they move very fast. And one key issue that I found in my research is the issue of health risk communication, where that has to be facilitated in a way that ensures trust in the planning and decision-making process. During COVID, one of the things that came up was, social distancing, wear your mask and do all of these, engage in all of these safety practices, but hardly will you hear about the need for effective waste management practices, and especially in Ghana, where there are healthcare facilities in people's homes. People use their homes for full healthcare facilities, right? And then when you look at the environmental inequity, racism, and class prejudice, the people that are working on the waste side, mostly women, mostly poor, mostly migrants, and they are susceptible to health issues through the social determinants of health. So with that said, now I'm going to end my presentation here and take a few questions. I've asked my class to hold on while I do this presentation. Sorry for the rush because of the class. Thank you all very much for listening.
Does anybody have a burning question? Anyone online? I do. I always do. So with your presentation, Jeffrey, thanks so much. I just wonder if you can, is there any thought that comes to mind in terms of very specific, actionable recommendations that you can give or that you can offer around proper or better, I won't say proper, just say better, biomedical waste management in Ghana and Rwanda?
Yes, sure. What is happening is there are constraints. These countries they are facing major constraints when it comes to resources, but there should be a way to work within these constraints. So first, it is recommended that one of the recommendations that I'll make is, in the absence of an effective or sanitary landfill, for example, it is advisable to bury the waste on site. Just make sure that pathogenic microorganisms are immobilized from the waste or separated as you disinfect them, and also make sure that it doesn't have to accumulate like that. With the accumulation, and I have a lot more pictures, with the accumulation, there are vectors that can transmit diseases to humans. So first, they have to find ways and talk to these healthcare providers about the need to bury on site. First of all, it doesn't have to be transported. Burying on site is not the best way. There's also cement encasing that can be used, and also, but when I look at what is happening, it's like the main thing is bringing awareness to the situation and also making sure that people are aware. I found that healthcare providers are aware through their occupational health and safety guidelines. They are aware that we shouldn't do this, we shouldn't do that. But the folks who come in from outside to carry the garbage, like you see the guy on that garbage tricycle there, no safety equipment, no personal protective equipment. And so all of this has to be brought to the attention of people, both healthcare workers and also waste pickers, that this has to be done. So awareness is the first thing, and then the absence of all of these resources, they have to take way to manage it within the confines of the constraints that they have. And on-site burial is one of these first steps. Never let it accumulate.
So one thought that comes to mind as well that might be interesting for you to think about in the future is there's always, whether you're in downtown Toronto or downtown Kigali, someone is always going to say there's a lack of resources, right? We don't have enough money to do the thing that we want to do. So in terms of biomedical waste management, maybe one thing to actually think about is changing the nature of biomedical waste, right? So a lot of products are plastics and metals and non-biodegradable materials, sheets and so on. It might be interesting, I'll just put it to you to think about for the future, what kind of manufacturing changes in the very structure and nature of biomedical products can actually be encouraged to facilitate easier and better waste management. And with that, I'll thank you, Jeffrey, for your presentation. I really appreciate it. And you're now free to go to teach your class.
Thank you. I'll come back.
Thank you, Jeffrey.
Thank you.
Thank you, Jeffrey. So our next speaker is Blessing. and I'm going to bastardize your name, which I don't mean to do, but I'm really terrible with names. I think most people have recognized that, but it's Blessing Ogbuokiri. Is that correct?
Fine. I'll project the right pronunciation for you on the screen.
Okay. And Blessing is going to talk about post-vaccination sentiment and whether it's possible to increase acceptance of booster shots for COVID in the global south, which is his big area of focus. And he's going to talk about using social media and very specifically Twitter as a way of better understanding and categorizing people's attitudes towards booster vaccinations for COVID in the global south. So over to you, Blessing.
Okay. Thank you, everyone. My name is Blessing Ogbuokiri, and it could be pronounced Ogbuokiri.
Ogbuokiri. So that's pretty close.
Yeah, right. I'm going to be talking about can post-vaccination sentiment increase the acceptance of booster shots, booster jab. So this idea was born through the fact that a lot of people in Africa, or even in the black community, they try to not to take the booster shot because they've taken the first shot or they've taken the second shot. They'll be like, I'm not going to take this again. I'm not going to take this jab again. And some also take it. They tend to complain that it didn't do much or they still got the virus after taking the vaccine. So why are they taking it again? So this actually, people also tend to send these messages to social media, which is where our focus is. When people post things on social media like this, it goes viral. Maybe they have followers, maybe they are influential, maybe they are so-called social media influencers, as we know. They say things and people are following, people are repeating it. Before you know it, it forms people's knowledge base. They tend to be like, oh, people are saying this, then I'm not going to take the virus, I'm not going to take the booster shot, and it becomes a norm. So that is actually what drove our to research, and we are trying to see if we can get the discussions going on social media, especially Twitter, how we can get what people are saying, analyze it, and be able to interface it with the existing data, which is the vaccination data. Are we able to, find a correlation between what people do on social media and their way of taking the vaccine? Is it affecting it positively or negatively? Is there any interaction between what is happening on social media and what is happening in real life and in local communities as well? So we use that, and we got first of all, got the vaccination record in 9 African countries, because these are our major focus. So we got the number of people that have taken the vaccine. We got the people that have taken, when we say partially vaccinated, we mean people that have taken the first jab. Maybe for some vaccines that require first and second doses, you have taken the first, you are expected to take the second one, so we will call you partially vaccinated. If you are fully vaccinated, it means that you have taken the first and second. Although there are also some vaccines that require only one shot, which is, if you just take that one shot, then you will take you as fully vaccinated. Then we have the booster jab as well. So we try to visualize it to make sure that when we look at it on a glance, you can actually see the countries that are being partially vaccinated and fully vaccinated. As the case may be, as you can see, the partially vaccination countries are the ones in red. Of course, these are our countries of focus, and the fully vaccinated together with the booster vaccination as well. Okay, so now what we have to do now to actually be able to interface what we are doing, what is happening in real life and what is happening on social media, we need to get the keywords that people could actually use, hashtags, to send messages on social media. One of such is the booster dose, second jab, booster shots, and all that. So we want to see the discussions around these hashtags. And our focus countries are the countries you see on the screen. So we found out that within the month of January 2022, there was a peak of the tweets as the trend that it was coming. The same happened between July and September. So this shows that there was high level of discussion concerning around this booster shot at that time. We wanted to be sure because the kind of data we got, whether it's actually it's relevant enough we found out that we did that word cloud that you can see that. We also found out that booster was one of the most highly more mention. It was more like it has more mentions than any other words. So that's why you see it's very thick there. So so this is the country's distribution of the tweets. I can just skip here because of time. And the next thing we did was to classify these tweets according to sentiment. So classifying these tweets according to sentiment, which I'm not going to go into much deeper right now, we tried to use machine learning after labeling the tweets to be able to, get the sentiment of the tweets. But what we did was when we finished getting that, we were able to get the intensity of these tweets. Because the tweets are not classified according to their sentiment, positive, negative, and neutral, we are not much concerned about the neutral sentiment. So we focused on the negative and positive sentiment. For the negative tweets, we found out that the intensity of these tweets were, they were somewhat negatively correlated, sort of. There's a correlation between the intensity of the tweet and the increase in the tweets. We also checked that as the negative tweets are coming, is it being retweeted and liked? Because, when people tweet something and another person likes it, it shows that, oh, it's being accepted. Or if someone retweets it, it means that even without verifying it sometimes, it means that you're also making it public to your own network, so it gets to a wider audience. Then I will find out that there's also a correlation there's a negative correlation between the two or the three. This is also important. However, there is no statistical significance in the I hope my okay. Okay, I don't know if I can see my mouse. Okay, there's no statistical significance between the negative tweet intensity and the retweets together with the likes. That means it's possible that there is a correlation, but it's not statistically significant. We also checked the increase in the negative tweet intensities, whether it's positively correlated with the booster shot. That is the real-life data, the vaccination data. We found out that there was a correlation as well. So meaning that there's a tendency that what people discuss on social media could actually affect the vaccination uptake, which could be the booster shot. Although at this time, it also has some statistical significance, but not that very, very strong. We did the same thing for the positive tweets. We found out there is a very strong correlation between the positive tweets against the tweets intensities. We checked the retweets and likes. We also said that there's also very strong correlation between the tweets and tweet intensities, their likes, and the positive tweets. Now, this tells us that it also says that it also makes sense to note that there is also a very high chance that people who have taken the booster possibly gave good report of the booster shot, meaning that they have possibly, it helped them or it didn't have an adverse effect on their body, so they said something good about it, and people were retweeting it in that order. And in real life, we also checked these tweets, the positive tweets, against the real life data, which is the vaccination data. So the increase in the positive tweet intensity also show the statistical significance that is positively correlated with the increase in booster shots. Now, it's not just about knowing the correlation. We want to find out what people are actually discussing in these tweets. For us to find out what they are discussing, we did topic modeling of these tweets using LDA. We were able to find out for 5 topics. One is booster safety, booster efficacy, booster type for Omicron, booster uptake, and vaccine uptake. This is very important because we want to even know, even in the local communities, what are they talking about these things. Okay. When we did that, for each topic, we tried to find out what are the tweets. These are just representative tweets. Anyways, what are the tweets that make up this topic? So what it means is that for every topic, there could be a sentiment. There could be a sentiment expressed on that topic. It could be positive, it could be negative, it could be neutral. As you can see, we have different countries and different tweets coming from them, and also different sentiments for the topics that they represent. So what we now did to do a distribution of these topics by countries, we find out that for topic 0, which is booster safety, it actually had positive sentiment in Botswana, as you could see. Then for Nigeria, you see that we have more of a negative sentiment on topic 4, and topic 4 is about vaccine uptake. Then if you go to South Africa, we had more positive sentiment for topic 3, Namibia and Mozambique as well. Okay, so in summary, we say that we also see that topic 3, which is the booster uptake, basically has more of a positive sentiment than any other topic in general. Then our findings, we find out that there is an average 45.5% chance of tweets discussing these topics to carry positive sentiment based on our data. Also, while more users express positive sentiment towards discussion on the booster uptake, which is topic 3, the rate of booster vaccine uptake in these countries are very low. So this is actually something one could actually, try to investigate more, because people are talking about this booster uptake and they are making positive sentiments about it. So why are people not taking it? Why do we have low number of people taking it? So this study is it is possible that this attitude expressed on social media could actually affect or impact the way people react in real life. One example of what is happening in social media that is affecting real life is what is happening in my country, Nigeria, where you see a movement that started as hashtag obedient, that they said it's only 4 people tweeting, and today the group challenged the electoral process in the country, which as a result of, before we used to say the tweets are basically for a class of people tweeting, but it's no longer that way, because what people say on social media somewhat gets to the real life. So I'm rushing, my time is fast. So concluding remark, post-vaccination sentiment can play a role in increasing acceptance of booster if people feel positive about their experience with the vaccine. They may be more likely to return to booster shots and recommend it for other people. And some part of this work has been presented in a conference which will be published very soon. Okay, appreciation. Thank you. Thank you, Blessing.
Any burning questions from anyone online? Can we just go online so I can see whether there's hands up? Perfect. Okay, that's great. And Roger, you're perpetually clapping there. I just put that out. All right.
I'm not perpetually clapping. I think it always ends at some point, but I don't want to disturb anyone.
Okay. Thanks. So Blessing, thanks for your presentation. I will point out that Blessing's paper is just published last couple of weeks, so congratulations on that. I just wanted to ask you to comment on your experience having done this. So when the COVID pandemic started, there was great interest, and this is not unique to COVID, but there has been great interest in the use of monitoring or looking at social media as let's just call it a phenomenon that has emerged relative to global health challenges. There's been a lot of discussion about fake news, about conspiracy theories, about different sentiments, as you categorized, in relation to COVID being expressed through social media. So what I love about your work, Blessing, is that you actually systematically looked at a particular phenomenon, COVID, and you systematically looked at a specific response in relation to a specific moment in COVID, so boosters, and tried to categorize sentiment in a particular moment around a particular intervention, and tried to understand that sentiment and tried to understand the relationship of that sentiment to acceptability of a booster. So that's essentially what you're trying to do, at least from my perspective. So what's your, I would say that what you've done is you've actually very carefully and systematically described a phenomenon and given some quantitative descriptive elements of that phenomenon relative to an intervention. But the phenomenon itself is not something we can stop, right? It's not something we can shape, but it's a phenomenon that has utility. So could you just comment on that? So it has utility in the sense that it can help public health workers, professionals, whatever language you want to use. It can help a public health response respond to a particular sentiment with new messaging, with new interventions, with new ways of shaping a particular attitude to, for example, boosters. So do you want to just comment on that?
Yeah. Thank you very much for your question. So it's just like what I asked Sally when she made his presentation, because the whole thing is about when we identify these gaps or these sentiments or these issues, challenges that things that goes around science, we try to present it in a way that policymakers can actually look at it as this is the identified problem. They draw a framework, a plan on how to address people or how to sensitize people towards this vaccine. Maybe before you deploy any kind of vaccine, you first of all start going to the local communities, start sensitizing people, maybe through the villages, talk to them, letting them know the essence of the need to take these things. And for the fact that people take it, you also try to let them know that it reacts differently in people's body. People can take it and it reacts in a way that they feel like they are feeling sick, but it's not like it's the end of the world or the vaccine is not working. It does work, but your body reacted differently. So those things can actually be said to the community, said to people that this thing is not a problem, rather it's just that your body reacted in a certain way. Because that is what is actually forming the sentiments that people carry along on social media. And sometimes people don't verify information before they share, as long as it's coming from an influencer or a reputable person that they believe in. You post it, they share it immediately, and it continues to go that way. So if people also can try to verify information before sharing, that can also help. So, I mean, that's...
Go ahead. Thank you, Blessing. Go ahead.
Thank you, Blessing, for the presentation. I'm sure many people in the room have probably played with ChatGPT, GPT-4, and its theory, how good it is. Right? And one of the concerns that's coming up around these large language models is that they can be deployed by bad actors to generate misinformation at scale, justify the process of spreading misinformation. So something like COVID or any other subsequent outbreak and vaccination could be the subject of this kind of industrial scale misinformation attack by bad actors. What do you do as public health people in the face of this coming wave? Because that stuff is out there in the wild, and it's going to happen.
Okay, thank you very much. So there's this thing called responsible AI and ethical AI. That is responsible AI such that for you to train any model, like we in AI, we work with public health people, they give us data to work. There should be laid down principles, the ethics. You get data that you have to obey the ethical principles that guide that the data. You don't have to go beyond what is expected of you to do when you're building your model. The responsible part of the AI is, when you get an inclusive kind of data, you don't have a data that is skewed to a certain people or that disenfranchise a certain kind of people, so that when you build your model, because it's about, just like ChatGPT you mentioned, it's about data. They have data, they train the model based on the data that they have. And if there's a question you ask ChatGPT, maybe ask ChatGPT a question about 2023 or maybe some part of 2022, it will tell you that, sorry, I am built on data from 2021 exactly. Meaning that as it is right now, 2021 and 2022 and 2023 kind of issues are not going to be captured in that, which is a little bit biased, sort of. So the whole issue about everything is building a responsible, ethical systems that can help in this.
People don't.
It's a what?
What if they don't?
No. There is.
I'd just like to point out. Thank you. I'd just like to point out that today, the big 5 tech companies just this morning announced in concert that they would like to limit and restrict the future use of artificial intelligence because social and political systems are not yet ready to respond to the shaping of use of AI for good. This is actually a sort of a big revolutionary moment that is literally happening today in terms of the future of AI and the future of digital systems. So your presentation and your comments, Blessing, are very pressing. So with that, let's just move on to the next speaker, and that is Professor Simone Bohn, who's an associate professor of political science here at York, and Simone is going to be talking. Just some of the things that she's involved in. She's co-editor of Mothers in Public and Political Life, and today she is going to be talking about state capacity and health equity in a post-slavery context, and she's going to be talking very specifically about the Quilombolas context in Brazil. And with that, Simone, I apologize for the brief introduction, but there you are. Over to you, Simone.
No problem. Okay. All right. Okay. So thank you very much for all of you for being here. I would like to thank the Center for the Seed Grant that enabled us to apply for SHIRK IEG, and we're developing data we plan on applying for a CIHR project grant in this fall. So I'll try to speak as fast as I can because I was thinking that I was supposed to have 10 minutes. So I identify a lot with Professor Harris' presentation because our research is also based on a community-centric research action, participatory action research design. And actually, we consulted with the community to develop our SHIRK Inside Grant proposal, and that's some of the results that we are going to see today. We were unlucky with things that are outside of our control because, for instance, the census data that we wanted to use, the census was supposed to finish 2020, then 2021, and as of today, 8% of the census is still to be done. So it is what it is. So my discussion pertains to how healthcare rights are actually realized in post-slavery societies. And I'm a political scientist, so I want to think about the projection of the state onto the territory and who is in and who is out in terms of practical access to rights. So obviously my colleague and our main argument pertains to like a combined effect of your race, ethnicity, and your social location. So I'm not talking about like this figure here, like of an independent effect. My main hypothesis is the following, actually. It's this one. So it is not the social location per se, your race, ethnicity, and social class, or just your territorial location, but it's the combination of both that shapes people's access to and experience with public healthcare systems. This is not moving. Where? I think it went. Oh, okay. So my main group, the group that I'm working with, they are called Quilombolas, and it's not a Portuguese word; it's an African word. So that's why I always use italics. And the textbooks in Brazil for kids and teenagers, and when I was at school, we always refer to them as former slaves or people who escaped slavery and formed free societies. They themselves don't refer to them. They refer to citizens who, citizens who were fighting an order that legalized the slavery. So, and then the groups that I'm working with are in the state of Rio Grande do Sul, about 12 million people. You can see the location in the map. It has 497 cities. 83 cities have Quilombola communities, and this total 195 communities. And it's the 5th state with the largest community of Quilombolas. And it's a very particular state because it was created by Germans who came to Brazil, and the second largest group are Italians. So these people are from the settlers there are from obviously a very, very different ethnic group. So there is a problem of invisibility of the Quilombolas in that state. So just for you to see, the state that I'm working with, and on the right, products of our work already, where the Quilombos are. Quilombos are like the communities. So in here are like the number of Quilombos per Quilombola communities per city, as you can see here. And we developed a lot of these maps because, like I said, I want to see where the location of things are and how that impacts people's access. And then here are the percentage of Quilombola communities that lack drinkable water, one of the key elements for the social determinants of the health. And I have other sanitation, whether they have access to regular trash collection and et cetera. But just for you to see that, there are several communities that lack even drinkable water, which is something very basic. Just to talk very briefly about Brazil, to me, it's clear that the state thinks of the Brazilian citizens as urban citizens and inhabitants of large capitals or large urban aggregates. And there are zero people in rural areas because of the way the healthcare facilities are spread throughout the country. It has public and private hospitals and a problem with the small number of beds vis-a-vis the population, and how these beds are concentrated in particular areas of the territory. So this creates problems for the Quilombolas who are in very isolated areas. See, this is one path for us to get to one of the communities. This was like the fall, but look at when it rains. It becomes like we can't navigate there. And so how kids get to school, how people get to hospitals, how they can get work outside of the community. And then when we go to the field, we have to drive on the grass, etc. And as you can see from the pictures, that is a situation of precarious housing, no sanitation and etc. And then this is the very south of Brazil, the southernmost state. So it's pretty cold there. Obviously not near as cold as Canada, but because of the conditions of the housing, it can become very cold, and people use whatever they can to keep them warm. So when one of the policies that this state, Brazil has 26 states instead of provinces, plus the federal district. This particular state has developed this initiative. It's called Healthcare Strategy for the Quilombola Families. And what they did, they give additional money for the mayors who have, Quilombola communities in their location. And we are trying to understand, the impact of these policies. And what do they get? They get extra money, and they have to, first of all, to have outreach initiatives to reach these communities, which are very isolated, very isolated. Our research shows that these groups are so isolated that sometimes they don't know that there are other groups like within 100 kilometers that are identical to them. They also are mandated to include the health, race and ethnicity data in all healthcare documents, have plans to address the issue of a sickle cell disease that's very high in this population, and they also have hypertension, and to develop clear goals and measurable goals that the state can address, can see improvements. So here's the percentage of Quilombola communities with access to that initiative. So just for you to see, obviously the areas in white, there are no Quilombola communities, so it hardly matters. The dark browns are the ones that have access to that policy. That policy also, some include healthcare and some not. So 41 cities out of the 83 agreed to be part of that program, and not all of them provide dental care. Most of them do not, close to 40-something% of them do not provide some form of healthcare. And our conclusions, moving quickly to results, is that, first of all, not all Quilombola communities know about these policies, and there are problems that we identified with, such as in the city Portão, in which the mayor applied for this provincial grant and got the provincial grant, but then he didn't inform the Quilombola community, and then he didn't provide services to them, and he got this extra money. And also, precarious access. Clinics, we have a lot of testimony. Clinics like doctors or medication, and also problems of institutional racism. When they go to these clinics, whose medical professionals are all German and Italian descendants, they are not very well received, even though those clinics receive extra money to receive them. How do they react to that? And then we are trying to think of their strategies of resistance. And, obviously they are creating more and more associations to understand what their rights are, to understand what kind of policies are available for them. And they are trying to participate in city level and provincial level, I would say state level health councils. And what they are trying to do as well is to leverage their, what we call in social movements literature, horizontal alliances. So groups from the organized Black movement in that state to help them get access to these health councils, because the key issue is accessing information to even know about these grants, to know who receives these grants and what kind of services have to be provided if those grants are received. So for us, for the next steps, what we're going to do is we have a field work in 8 rural communities and 8 urbanized communities. And I say urbanized communities because all these Quilombola communities were founded, slavery was abolished in 1888, so they were formed before that period. And they were all rural, but the cities grew. It's not that they were founded in urban zones, it's that the cities were the ones that got to their areas. And then, so what we're trying to do is to understand the difference in experience, the difference in access, the difference in knowledge about these policies. And also we want to understand that, what's the role of the healthcare agent? Because this policy demands that these healthcare agents are created, are trained, and that they go to these communities to inform their communities, which goes back to your questions about trust, about who these agents should be. The community wants community members, and then obviously the state wants other people. And, understand better their experience. Those who go to these clinics, what kind of experience do they have? The role of community healers that they have. And, also one issue that we're trying to understand is what about their oral health if they have zero access to dental care? So that's it from me.
Thank you. Go ahead. I have a question. Go ahead.
Thank you very much for the presentation. I was just thinking, as a first-year anthropology student, I learned some stuff that was new to me, but it might be helpful for you or if you already know about them. There's a lot of people theorizing about the afterlife of slavery.
Yeah.
We're talking about slavery, there's the work of Donna Shange, and then Ashia Linde, and I don't know, James and of course Maggie, who's online, would know a lot more than I do, but I just thought maybe that would be helpful in terms of theoretically shaping your approach.
Yeah.
Because I found it incredibly helpful in my work, actually, just to sort of understand that and all of these after effects continue to ripple in the environment, and of course, the shape, in addition to slow and structural violence, what people are living.
Yeah, we have several Latin American authors that talk about this, Maria Lugones and Aníbal Quijano, who talks about the violence of the colonial legacy, and also especially Brazilian authors that talk about especially Brazil, which is the most African country outside of Africa, which received the largest inflow of transatlantic slavery, was Brazil, not the United States. So and then we have some Brazilian authors that work with the idea of America instead of America, the American continent, America, because of so much African influence and the way the racial group shaped the nation state of Brazil, and the importance of rescuing this. Understanding, acknowledging this colonial legacy and addressing them, because the key issue is that these groups have remained in isolation because since the abolition of slavery, there have not been, public policies to address their needs. It's unbelievable that they are so isolated, but also obviously the other side of their isolation is like their strength. They are very well organized. They live in, societies with a large number of families, like 40 families. They all live, they develop solidarity, they have harmonious relationships, and so on and so forth. So they have found ways of resisting their, material conditions of existence.
Roger, I'm just going to ask, Roger, go ahead.
Thank you. That was really fascinating, and I'm looking forward to reading more about your work. My question goes back to some comments that Harris made an hour ago about the village and in sort of an urbanizing West Africa. And you very explicitly talked about urbanizing areas with organization of the political in different modes. And there was in political science and in sociology, to capture two disciplines from where the two of you come and where you situated yourself both. There has always been an idea that as we become more urban as a species around the world, and as societies come, as societies develop out of communities, that politics would reflect that in some ways. But both of you, Harris made the comment about the villages, and I have had many conversations about this. And you made a connection between an urbanizing society, but the persistence of these post-slavery forms of community organization, both social, spatial, and also political. And I'm curious about whether you can say a little bit more about your concept of urbanizing. Is it like the Indian state or the Chinese state? They declare certain parts of the country urban, and then they become urban, whether they like to be urban or not, and then development is possible, or whether you have a more socio-spatial or socioeconomic concept of urbanizing that says, I have some criteria by which I can call this urban versus rural. So if you could elaborate a little bit more on that.
Yeah, I think one key element, I think, that of this discussion is like Brazil has undergone a very fast process of industrialization from 1930s up to the 70s, and very, very fast. And with that, a lot of people moved from the countryside to the cities. So the process of urbanization lacked, urban planning to a great degree. So it was very organically driven and not regulated by the provincial or federal authorities. So what I like to tell my students that my Latin American courses is that when you fly over Canada, you see that grid formation, and then you know where the roads are, and etc. When you fly over these regions, you see like a mass. So it's very difficult to it's not very well organized. So it was very organically driven and not regulated by the authorities. So we have clear criteria to separate urban versus rural areas. And we talk about semi-urban areas as well. But the key point is the fact that this was not planned. And as a consequence, we obviously, I'm sure you know, we have slums and that have never been regularized in terms of access to public services. And we also have like the situation of the Quilombola groups in urban areas, like for instance in this region where I study, in the capital city, Porto Alegre. So there is a large Quilombo in a very posh area. And then these neighbors are encroaching upon this land. And of course, the Brazilian government never gave the land title to the Quilombolas. And as a consequence, there is a massive fight over that land. And the neighbors don't want them there. And at the same time, that piece of land is worth several $1 million. So it creates a lot of conflict. So land is a key issue for these groups, and not all of them in Brazil have their land titles. So I think these are so not all of them are land secure, but the ones who are land secure have more economically prosperous communities.
Yeah, thank you. I just, there's something else in my, the back of my mind, which I'm influenced by the thinking of Roberto Luis Montemor at the Federal University of Minas Gerais in Belo Horizonte, who has seen this urbanizing process somewhat, in an opposite way, not to see, as you just said, that, people are moving to the city and become urbanized, but he actually talks about the Amazon, for example, as being urbanized by, the political economy of urbanization based on a Lefebvrean understanding of urbanization. And I think that would be, could be another influence on your thinking there, which I would love to talk to you more about in, reconceptualizing urban and rural in this context, because of your empirical work being so rich and delivering exactly those kinds of things that Montemor finds for the Amazon. So we can take that offline somewhere. Thank you very much.
Yeah. I was just going to say that the Amazon is another beast, because there was the military dictatorship from 1964 to 1985, and the military had an interest in colonizing those areas. So it was essentially like a government-driven process of urbanization, and for very authoritarian reasons. But yeah, I'd love to continue talking to you. Thank you very much for your time.
Thank you, Simone. Thank you. So our next presentation is by Maggie MacDonald. And Maggie is a medical anthropologist, professor at LAPS. And she has a specific interest and expertise in gender and health, and especially women's reproductive health. And she's going to speak today, Maggie, about how is the drug Misoprostol being used in humanitarian emergencies for reproductive indications. And she's going to explore that, particularly in relation to medical abortion, and also, I think, explore a little bit about how access to safe medical abortion is actually missing in most major humanitarian emergency settings. So over to you, Maggie.
Great, thank you. I just want to make sure that I can share my screen. Is that enabled for me? I'll just give it a go and see what happens.
Yeah.
Yeah, okay, great. I just want to, okay, well, first of all, thank you to the Dahdaleh Institute for the Seed Grant, which got me started on this research. And it would be great to be there in person with you. I can see some familiar faces around the table, but alas, I'm on sabbatical and abroad. So just as James discussed, the presentation today is about a drug called Misoprostol, and I'll explain a little bit more about it, but really briefly, it's one half of a clinical regime for safe medical abortion that is non-surgical medical abortion. And I think that some of you might actually be a bit more familiar than even a year ago, given the striking down of Roe v. Wade in the United States, which really was a catalyst for a lot more conversation about safe medical abortion, and the kind of activist groups and accompaniment models that have really grown up around it. So a year ago, I used to have to explain a lot more what I meant by this, but it'll be a little bit more familiar for those of you who've been following the issue largely in the States, but in the trickle-down effects, as we'll see here as well. So okay, so the project. So the Seed Grant was basically to really start at the beginning and do a metasynthesis of the research literature, and by that, and to take a critical social science perspective on that emerging literature. And, you know, as I found and as I knew anyways, there was very little research literature about it in global health, and not yet specifically humanitarian operations. So I was familiar, and there's lots of literature about misoprostol as a drug, because it's got several reproductive indications. It's a uterotonic, so it can be used to treat and to prevent postpartum hemorrhage, which is a major cause of maternal death, and also for post-abortion care, which, regardless of the legality of abortion in any country, is a treatable condition, and is also often treated by the same means, by the same drugs and some similar surgical techniques that one would use for a safe medical abortion. So I wanted to look specifically at how this was playing out in humanitarian operations, knowing that there was the little research I did know and that did exist was saying that it was really absent. And so I'm following this long-term interest I have, obviously, in maternal mortality, and then the role of the drug misoprostol, and following it into humanitarian operations. So I published on misoprostol and maternal mortality and its causes before. So what do we know very quickly? Unsafe abortion in humanitarian settings is the norm. I won't go through all of these in detail, but just to say that of the many millions of people living in conflicts, disasters, forced displacement, 1/4 are women and girls of reproductive age. And as we all know, threats of sexual violence and rape as a tool of war are more acute in crisis. And then, so exposing women and girls to unwanted pregnancy. And then we also know that as the quality you know, in crisis settings, quality and access to reproductive health services go down as health infrastructures are destroyed, as people are on the move, as people are unable to access. And then just as a quick bit of data here, the maternal mortality ratio, which is the MMR, is twice as high in fragile and conflict settings, often well over 1,000 per 100,000 live births, which is the ratio on which it's calculated. Just for a quick comparison, Canada's maternal mortality ratio is probably about 3 to 6. In places like West Africa, developing countries, example of Senegal, it's in the area of 270. But very recently, and just because this has been on our radar today, Sierra Leone, post-war, during the war and post-war, it was as high as 2,300. So it's really a serious unsafe abortion. If I was to show you a pie chart, accounts for between 8 and 13 of all maternal deaths, and it always has. And this is one of the reasons why this is called a neglected crisis within a neglected crisis. And in fact, UNFPA estimates argue that it's even higher. 25 to 50% of maternal mortality can be attributed to unsafe abortion. So that's a really dire situation. So, okay, so quickly, what I'll just do is jump down here to policy and clinical tools. So we know this background, but interestingly, there are already policy and clinical tools already in place, and I'll share a bit of that in a moment. Very little clinical research is being done for many reasons, and very few organizations that are intervening on the ground in humanitarian operations are offering what you would describe as comprehensive reproductive health services certainly there's obstetric services being offered, and certainly other things are lacking, like family planning and obviously access to safe medical abortion and post-abortion care. So we've got the this situation, and this is the title of one of the articles that I looked at when I was doing the review. It was stated this starkly: why don't humanitarian organizations provide safe abortion services? And that was in 2016. And there's been a bit of progress, obviously, since this time. The usual sort of situations described in the literature is that there's lack of data, and then lack of data sort of lets us put the issue aside. If we don't know the severity of the situation, then we don't know that we have a problem, and then we don't create interventions to create it, to address it. But several of the authors that I read said, in fact, that also that there is unclear information about the legality, so that when they looked at why the reasons most often given for not offering comprehensive reproductive health services, including safe abortion, is that there was unclear information about legality in different settings. And so often humanitarian interveners said it's illegal in this country, so we can't offer it. Others said that it was too complicated clinically, which may have been closer to the case when safe abortion was largely managed through surgical means or through manual vacuum aspiration, but no longer with the existence really of safe, tested, available, relatively straightforward to use, and cheap drugs. In the case of Misoprostol, in any case, cheap drugs. And then there's also the perception amongst operators in humanitarian operations that donors don't fund comprehensive reproductive health services, that's not what they're there to do. They're there to save lives, and they're saving people's lives, you know, with primary health services, nutrition, water, and so on, shelter. And also it must be said then that the US policies create the chilly climate and have for decades. It's not just the striking down of Roe v. Wade, it's years of formal US policy that prohibits US funded operations, development, and humanitarian from offering safe abortion information, referrals. And Misoprostol as a drug, I'll just make a quick aside because this is important. Misoprostol as a drug, this US policies around abortion blocked, muddied the water, created, say, the chilly climate, even for the use of misoprostol for something like postpartum hemorrhage. And so when you've got postpartum hemorrhage happening in rural and remote areas, and there's no alternatives, and US policies clouded in the abortion debate are preventing misoprostol from getting out to remote areas to treat postpartum hemorrhage, it's a serious medical and moral issue. So I will just, how did misoprostol, you know, sort of get this up, this reputation? It really started with abortion activism in the form of clandestine accompaniment, model distribution and use, largely coming out of Latin America. And this actually hampered the clinical testing, the regulatory processes, the registration of the drug in countries. And even when all of that was in place, it affected its uptake, even where it was legal, available, tested, regulated. And so you've got this kind of strange history with this drug, and that I think is still hampering it today. So I'm not going to go through this slide in detail, but I just wanted to put it up here. You've got a list there of what I would call policy moments in the social life of misoprostol and its role in safe abortion. So safe medical abortion. And so you've got a history there that really starts with the 1994 ICPD in Cairo, the International Conference on Population Development, and then a series of policy statements, of clinical protocols, of consensuses, and even up to WHO and International Federation of Obstetricians and Gynecologists, all these policy statements that start to accumulate, and I call them policy moments in the social life of safe abortion. Obviously, I'm taking here a critical social science perspective on following a drug through its social life, its clinical testing, its regulation, and its uses. So, coming up to like a more current moment, then all the sources in the review begin with the observation that despite policy and clinical guidelines being in place, despite medical tools being available, access to safe medical abortion is still missing in the majority of humanitarian settings. And there, sorry, I've got a quote there for you from one of the most recent publications, Kumar et al. So at this point, I'm just really going to turn to some of the emerging themes that I found in the literature that might become apparent, that might be apparent already from what I've said, is that safe medical abortion is characterized in the literature as a neglected tragedy within a neglected tragedy. So for those of you who might be familiar with the history of the global campaigns to reduce maternal mortality, starting in the 1980s, it was characterized as a neglected tragedy, and that was it was dubbed the neglected tragedy. And so when I see that kind of rhetoric in the literature, it makes me think of it as a neglected tragedy within a neglected tragedy. And indeed, it's one of the few sort of major causes of maternal mortality that is really still not being properly addressed and not addressed in humanitarian settings. So you've got this series of significant policy moments about the absence of access to safe medical abortion in humanitarian settings. And what I started to think about was that there comes a point where there's a policy plus evidence tipping point. And I think we're there actually in 2023. There is an accumulation of policy. As I said, this long list, that's only half the list of these policy statements of professional associations coming out and saying, this is an issue, we're behind it, we've got the tools. Motivated researchers producing evidence and commentary. And this is really significant. You've got people who are placed in university settings or sort of research. I think of them as research think tanks because they're actually doing advocacy through science as well. And they're producing evidence and commentary. And then you also have evolving rhetoric. And what you see here, and this was the case true as well with maternal mortality, is making the case with science. And this was really true of making the case for the use of misoprostol for postpartum hemorrhage as well, is that in the literature you see, the rights rhetoric always runs alongside, but that the case is really being made with science, and researchers are very careful to make the case on that basis, and also what I would call a biomedical logic. So that you see researchers, as you read between the lines and how they present their research findings, they're using phrases like it is sort of medically unnecessary. I'm blanking out on some of my own. This idea that it's inconceivable not to address it if all the tools are necessary, that it's medically just not sustainable to not address it. So at the same time, you see with the emergence of misoprostol is the emergence of a new medical protocol that has been tested and true. That means that the "it's too complicated" argument cannot be used as a shield. And so you have some commentators who are also researchers, and this is very common in this field, who are saying that the "it's too complicated to perform safe medical abortion" has been used as a shield, and that this is no longer true. So, and then I would say, which, as I'd mentioned already, another thing that is kind of emerges in this case of misoprostol and access to safe medical abortion is what I would call convergence. The striking down of Roe v. Wade in the United States, as we saw in Canada and elsewhere, increased calls for telemedicine during the COVID pandemic directly at reproductive health care, saying, let us get on the phone let me doctorate physicians in Northern Alberta, for example, I remember some media coverage said, let me prescribe my patients this particular drug. We'll do a telemedicine work with her. And also what I saw, which I found was really interesting most recently in the Kumar article that I just quoted from, is what I would call the models of accompaniment and self-care. Self-care agenda at the level of the WHO in reproductive health care is really it's been there for a couple of years, but the kind of joining and so suggesting even that you can use these accompaniment models and self-care even in a humanitarian setting, that you can prescribe drugs, you can describe the protocol, and you can have this kind of, in this case, maybe not telemedicine, but medicine at a distance, or medicine in a kind of with community level providers. So I think that might be my last slide. And that, if I'm right about that, I will. Oh, who's doing what? This is super important. You have leadership. So my last point on the last slide was leadership. And you see leadership, Médecins Sans Frontières, for example, and Save the Children, less high profile way, are explicitly, they've begun to identify safe medical abortion as a critical moral and health issue. And they've started implementing programs, evaluating them, and sharing findings. And also in the literature, you see calls for qualitative research, calls for action, and new ways of shaping the dialogue. So I will leave it there and escape from my presentation and stop sharing. Let's see. Thank you. Someone else stopped sharing for me. Thanks.
Go ahead.
Hey, Maggie, when I was in Sudan, I think we've talked about it, but MSF were providing abortion services. So just when you were speaking to legality, if they had publicly said they were providing abortion services, they would have been thrown out of Sudan. So I'm just wondering about the difference between what people say they do for academic articles and then what they're actually doing on the ground. Those women who are crossing from Ethiopia had experienced severe sexual assault and other forms of abuses. So they came over HIV positive and also often pregnant, and MSF recorded them both, and I'd be happy to connect you to the people who are running those projects.
Yeah, no, this is a really kind of particularly kind of interesting. It's almost pre the research literature, but so I think you're absolutely right. I think there's been more of who's doing what that hasn't been talked about. I could say more about that, but that I think to get at that, to sort of dig around in that area would require the qualitative research interviews, which might be the next part of the research. The only other thing I would say is that there's some very determined individuals who are also essentially saying that if you really pick apart the legality, there are very few countries in the world that prohibit abortion in all cases. And so that if this is better known by physicians, for example, this is better known by people operating in country, and if that can be better known, that you can also figure out ways to just say, I'm operating in a legal context here. This is a woman whose life is in danger, and so that there's a provision for that, or for rape or for rape. So there is a provision for that under the law, but if people aren't aware of the finer points of the law, then and this chilly climate around, very chilly climate around abortion. So yeah.
It'd be chilly for the Americans, but if you think every time the Americans do this kind of stuff, the Scandies step up and Canada steps up every time. Norway, Sweden, Canada, and then we fund what they don't fund. So.
Yeah, but I heard, even with misoprostol for postpartum hemorrhage, I heard stories of people who were like medical professionals, nurses and doctors who were invited to sort of trainings about misoprostol for postpartum hemorrhage, who didn't go because they thought that their organization would lose their funding even if they sat in a room where somebody talked about misoprostol for postpartum hemorrhage. So it can be that chilly. They got calls, and they got calls. They said they had been called and they were told not to go to the meeting. They were afraid to go. So, yeah, but really excellent point.
Also, just like to point out that many of the issues, Maggie, that you're pointing out, this kind of discontinuity between clinical practice, between science, clinical practice, and policy. This is yours is a very good example, but there are many, many other examples of that phenomenon. And so, just to give one concrete one, exactly the same disconnect exists around female genital mutilation. Exactly the same disconnect exists around the application of humanitarian law for protection of civilians in conflict. The very same sort of disconnect exists around the use of torture, in particular settings and contexts. But so when I step back and sort of look at all of those examples, which have, similar kind of elements, at least structural and functional elements to a sort of a policy change process, one of the things that it's very clear, and it's come out in your talk, is that for humanitarian organizations like MSF and many others, what they do and what they say publicly, and also what they report in the academic literature are very different, right? And because of that disconnect over time, but the intention is very clear. Particularly in your case, in the case of what you're describing, the intention is very clear, which is to improve the science, to improve the clinical practice, and to make sure that people, women, have access to the best possible care and the best possible set of options in an emergency setting. Now, the context and the legality of that is often a big challenge. And I just point out that law often is not necessarily about the good. It's about the powerful. It's about who decides what, when, and under what is permissible under what circumstances. And so this is just sort of it's just a reflection, really, more than anything, that I'm offering about the nature of change over time, and how important the kind of things that you're talking about, Maggie, the importance of great science, the importance of very, very focused clinical interventions, and the importance of consensus around those interventions, and then the importance of advocacy and engaging advocacy in a manner that is very mindful, whenever you talk about sex, life, and death, those are kind of big issues, and they're culturally specific, and how cultures talk about those things and advance in their thinking around and their practices around those things, by definition, is controversial. So with that, I'm going to just ask you, Maggie, do you want to reflect on that? And then with that, we'll go to our next speaker.
Actually, can I actually ask a question?
Oh, sorry,
I've been
Eric,
waiting quietly and patiently. Yeah, thanks.
Go ahead.
No problem. Maggie, thanks so much for your presentation. I'm just wondering whether you could speak a little bit to how you, as an anthropologist, move from this type of engagement with the literature, the policy texts, the literature that you cited, and your own work on the sort of the social life of Misoprostol. How do you move from that to formulating a research question? Like, can you talk a little bit about where you're headed, where you think you may be going? You mentioned a little bit about some maybe qualitative work. Is there a particular, like the scale of the analysis? Would you focus on some particular sites for research? Are you going to be doing where it's so interesting? We'd really love to hear more about where the next steps are and how this preliminary stage informs your methodologically where you're going next.
Yeah, I think the first thing I want to do is actually, publish this. I started to talk about it as a kind of metasynthesis, but I think it's destined for a journal that takes a kind of STS approach, or anthropology of science, medicine, technology, to give a kind of critical read on this. Next, I imagine, and I might have a graduate student coming to York to do it. Next, I would imagine conducting a series of, I guess there's two ways to do it, to do something quite broad, to look at it, to look at conducting a series of qualitative interviews sort of across humanitarian organizations, to try to get at, to dig a little bit deeper into the, some of these differences we've been talking about what they do on the ground versus what they're able to say publicly, what they're able to share in publications. And I think another route would be something that was more ethnographic in a particular region, in a particular setting, like a protected humanitarian emergency, a long-term refugee camp where it's possible to actually conduct research. And there's many of those kinds of connections at York. So I think that that's where I would head with it. The possibilities in some ways are quite endless, because I think this push, and one of the other things I'm really interested in is this new declaration from the WHO about self-care and the trickling down of small accessible handheld technologies and protocols that can be used at the local level. So it's something else. This is of a piece with that other interest that I have about biomedical objects being used and their users, whoever those users might be. So I don't know if that is helpful.
That's very helpful. Thanks so much, Maggie.
Yeah. I mean, I have a long-term interest in I was just going to say, in activists and in people getting ahead of medical curves and doing things outside the system. And that's one of my long-term interests. So I think that's what keeps holding my attention and the thread that I'll keep pulling through here. But thanks.
That's great. Thank you, Maggie. So we have one more presentation on prior seed grants. And I'm just going to say that in the interest of time, we have to be out of here by 12. So we have a bunch of presentations, which I'm going to ask people to hold off on. We'll find another opportunity for people to, for Hillary, for James, for Imran, and for BK. We'll find another opportunity for them to present their ideas. But I would encourage those 4 people, as well as all of others online and other faculty and fellows at the university, to apply for seed grants, which we're going to talk about following the next presentation. And I'm going to ask Pablo to speak now, but I'm really going to ask you, Pablo, perhaps unfairly, to try to stay within the 5-minute time limit that was set, but that is what it is. So Pablo Aránguiz is an associate researcher here at York at the Young Lives Research Lab, which is run by Professor Kate Tillage at the Faculty of Education. Pablo is an expert in participatory action research, and he's going to talk about decolonizing planetary health through the, I think the pronunciation is Wiki, but I may be wrong, through Wiki Ecologies of Repair. And with that, Pablo, I'm going to turn it over to you. Please go ahead.
Okay, thank you very much. It's Williche. So thank you very much. I'm really glad to be here. My name is Pablo Aránguiz. I'm from southern Chile, the Chiloé archipelago, which is in the northern gate of Patagonia. I am a community-based researcher and practitioner, and I have been working with indigenous Williche people during the last 20 years, and mostly supporting the political struggle against the Chilean government. And I'm an associate researcher at the Young Lives Research Lab. And currently I'm doing a PhD research at the Universidad Politécnica de Valencia in Spain. So this research is part of a larger process in order to create a partnership with youth on planetary well-being in the Americas. And so, let's see here. Yeah. So the notion of planetary health provides an opportunity to achieve the challenges imposed by the Anthropocene. Much remains to be done to ensure that planetary health does not become an empty concept used to reinforce the status quo. So in that sense, call to expand the paradigms of planetary health is basic, such as relational, intergenerational, and indigenous approach are always welcome. So there are two important challenges to consider that we want to share with you in order of planetary health not to be transformed into a new colonial concept. The first one is the assumptions related to time. And that is important because one explanation for the inability of the global governance system to solve climate change issues is based on the notion of time coming from the Western tradition of thought. So from this tradition, time is always visualized in a linear and progressive way. That is to say, time is constituted in an imaginary composed of at least 3 stations that are disconnected from each in an exclusive manner. In this rationality, the past refers to something disposable, which can be denied and must be overcome. The present is conceived as a now that is disconnected from the life history. It's about today as a unique event. Finally, the future appears as something non-existent, since it's located as tomorrow, as something that will permanently come. In contrast to modern colonial linear understanding of time, Silva Rivera Cusicanqui and other indigenous scholars argues that times in people, history, and memory move in circles and spirals, marking a course without ceasing to return to the same point. The indigenous world does not conceive history linearly, and the past and the future is always contained in the present. The second key challenge is the central role that technology, materials, and infrastructure assume when interacting with communities in generally unaccounted for and often harmful ways. The carbon tunnel vision and the imposition from the global north of an energy transition based on techno-optimistic approaches allows continuation of the violent human rights abuse when developing greener technology and energy projects. Importantly, for any new paradigm to meet the joint goals of health, sustainability, and justice, it must implement reparations. According to Julia Paulson, recently what might be called a reparative turn is being visible in social science and humanities. And that is because reparations are more essential than ever in the context of a climate crisis. So what is interesting is that reparations are not just a way to address past harm, but a war-making project to build just and ecological futures. Having said that, it's important to count with place-based responses to planetary health. Our environmental case study corresponds to the repair of an old water mill of Spanish origin by members of the Williche indigenous community of Huequetrumao, Chiloé archipelago, southern Chile. The repair process was recorded for the production of the video documentary El Molino del Abuelo Juan, or Grandfather Juan's Mill. So you can see Chiloé archipelago is located in southern Chile. It's made up by 40 mostly inhabited islands, and the population is 170,000 people, from which 65% are part of the Williche indigenous. So although Chile is not a major greenhouse gas emitter, influenced mainly by international environmental commitments and under neoliberal capitalist environmental politics, since 2009, the Chilean government has developed a set of regulations to address climate change by supporting a transition to a lower carbon economy. This momentum has encouraged the proliferation in Chiloé of several large-scale wind power generation projects, making Williche territories a new type of green sacrifice zones. In this historical and present socio-ecological context, the Williche people of Chiloé carry out a series of repair practices based on a set of knowledge and tools that allow them to address what has been broken. It is not clear when these mills were introduced in Chiloé, but it was associated with the arrival of the Spanish settlers for the massive production of wheat. Therefore, the arrival of this technology meant a great transformation in Chiloé family's life, turning the molienda, or act of grinding, into a local institution. Now, this mill was used by the community for at least 30 years until the owner became ill and passed away. In 2018, the repair process was done through a series of mingas, or collective work, to which I was invited to be part of. So the obvious question is, why repair an old artifact that is obsolete, since, for example, flour can be easily purchased in any local store? So following the long tradition of science, technology, and society studies, this is a response to planetary health justice based on a post-humanist perspective and Williche knowledge. As Chiloé experienced climate coloniality through green grabbing, loss of biodiversity, chemical and plastic pollution, rising sea levels, zoonotic diseases, rising sea temperatures, and its consequences on algal blooms, population health, among others. So in order to do that, during 2022 and 23, we have had a series of conversations through Williche ways of knowing and qualitative research techniques. This included 2 roundtables with Williche youth who are in the process of designing an intergenerational model of co-governance of marine spaces. Viewing the documentary video and through conversation with elders, the notion of reparation was collectively reflected upon. Through our conversation, the ecological crisis emerged as a symptom of a sick planet. Williche reparations implies recovering ourselves as children of Mother Earth, that is, the set of relationships that sustain the human and more than human community. For Williche youth, reparation means to look again and reconnect with the territory from Williche values, such as solidarity, conviviality, and reciprocity. But more important, for Williche youth, reparation is an act of care. Viewing the documentary through a post-humanist lens, the mill is understood as a colonial technology that is appropriated through Williche values, transforming itself into an immaterial device that flows through the web of relationships, not only of human and more than human, but also of time and space, connecting the past with the future. In that sense, and according to what was expressed by community members, the mill is a modern device useful today to address contemporary issues through community-based education and land-based education. Finally, the appropriation of a colonial technology by Williche community for their own purposes offers an opportunity to expand planetary health research. In that sense, I'm very interested in the opportunities that might be offered by lab-per-person notions of cyborg with an S as the structural agency of persons who have picked up colonial technologies and reassembled them to the decolonizing purpose. Thank you very much.
Thank you very much, Pablo. Any comments or questions? Oh, sorry, Kate. Go ahead, Kate.
Thanks, James. I just want to say that was just gorgeous, Pablo. First, that you stayed on time with so much to say, and also just your pulling together, your bringing together of this incredible project that gets to the very heart of this larger partnership for youth and planetary well-being that I know that we're all part of trying to do, and to center the lives of young people, to support, empower around this notion and theme of reparation is just really, really powerful. So it's not a question, but a comment. Thank you very much. I really appreciated that.
Yeah, Pablo, that was just a fantastic presentation. And I have a comment as well. which I would invite you to kind of reflect on. Some people here have heard me refer to this in the past, but I'll just say it again. There's a very significant technology philosopher who passed away recently, named Ursula Franklin. She was here at University, or in Toronto, at University of Toronto, and she was an engineer, a metallurgy engineer, and a specialist in alloy metals, and a globally renowned researcher in that regard. But she also studied the use of technology in different cultures and in different times. And she came up with what I thought was probably the best definition of technology that I've ever heard. And it really comes to mind in relation to what you've just presented. Her definition of technology was not about things or objects or about the next new thing, but it was about objects and culture and the way in which one shapes the other. And she said that her definition of technology is very simple. It is, quote, the way we do things around here, period. So the way we do things around here, in the context that you've just presented, really just offers, at least from my perspective, a completely new way of thinking about, quote unquote, old technology and its relevance to the future. Could you just comment on that, Pablo?
Yeah, I think that definition that you just shared is really in line with what some scholars are definition of indigenous technology, which is exactly there are ways of knowing, in some cases tools that allowed us to overcome that separation between human and nature. And I think that this case that I have shared with you is, as you just said, is seen in a critical way what we understand as innovation, for example, and put it a value on what is more resilient, for example.
So with that, thank you, Pablo. And I'm going to now ask Hannah to talk with us about how to apply for seed grants. And it's going to take about 2-3 minutes, and I'm going to turn it over to you. Go ahead, Hannah.
I'm going to go through the whole presentation, but I'm not going to go through the whole presentation because we are out of time. But I'm just going to highlight a few things that's new this year for our seed grant. The application form, it looks like this. It's very easy to fill out, and you really just need to attach one page, 500 words, 2 pages double-spaced, of your project summary, another page for your budget, and it can be as simple as just attaching a table with your expenses. And this year we also included an equity, diversity, and inclusion measure, and that is something that is not required, but will be taken into consideration if you do fill it out. And yeah, that's essentially it. The last 2 questions are just a survey to help us plan for future workshops like this. And I think the more important thing is that the seed grant application deadline is quickly approaching. It's set for Monday, April the 10th, and we should expect to have a list for the results back by Friday, April 28th. So all this information will be officially announced by the end of today on our website, dijdhr@yourcu.ca. Apply for us. And you can also find it across all our social media channels if that's easier. And throughout the application process, if you have any questions, just email us at diresearch@yourcu.ca. Sorry, that went over.
No, that's great, Hannah. That's great. That's terrific. I'll just mention, too, that eligibility, the primary grant applicant has to be a York faculty member. Postdoc fellows and graduate students can co-apply with a York University faculty member. And those outside of the university can co-apply with
I think you may be muted there, James.
Can you just turn me on? This grant is so easy. You will never get an easier grant, and it just takes very little time to do it properly. And then with that, Hannah's already pointed out that the deadline for application is April 10. So it'll take you a couple hours to fill out the form. Think it through, fill out the form, and then we have an adjudication committee, and we will meet and announce the recipients by April 28th. And all the information is on the website. It's so simple. All you got to do is just sit down for an hour or two and do it. Now, with that, I'm going to close the seminar or the workshop and thank people for really just great, fulsome presentations and discussion, and also apologize to to BK, to James Stinson, to Imran, and to Hillary that we didn't have time to actually have your presentations. But I encourage people to talk about those presentations over lunch. I'm just going to give you the titles just so you know what people are thinking about. So BK is preparing a seed grant application around citizen science and digital apps as community-based participatory action tools for complex adaptive systems modeling. And James Stinson is preparing an application around Maya youth and the future of planetary health in southern Belize. And Imran Ali is preparing a seed grant application around can community-based participatory water quality monitoring enable forward accountability in refugee and IDP or internally displaced person settings. And then Hillary Birch is preparing a seed grant application on state capacity during COVID-19 in Toronto. And so with that, I'd like to thank everybody for attending and participating in the workshop, particularly our speakers. I'd also like to particularly thank Hannah for all of the hard work that she's done in preparing this workshop. It's really, it seems easy, but it's an enormous amount of work, and Hannah's done a great job doing that. So just like to encourage everybody, give her a round of applause. Lunch is available. Let's enjoy, and there you are. Thanks so much. Thank you.